afternoon to all of you, and welcome to this final round of Tysa. I think you've all done very well, and I wish you all the best. And it's the participation which is very important, and hope all of you enjoy the program. All the best.
The presentation of I will introduce the faculty who are going to judge you. Professor Rakesh Sahai, Professor and Head Usmania. He will be examiner for some of you, so just please present nicely in front of sir. Dr. Pankaj Agarwal, he is a senior consultant endocrinologist from Ghaziabad. This is the presentation. Welcome, sir. Please welcome Dr. Sanjay Kalra, past president ESI. So we are just introducing the faculty. So most of you know, but it is customary to introduce. Dr. Sanjay Kalra will be one of the faculty members. Dr. Rakesh, I already said. Dr. Pankaj Agarwal, I will not be the faculty. Dr. Pankaj Agarwal, endocrinologist from Ghaziabad, and Dr. Somshekhar Reddy will be joining us soon. Will be there after some time. Dr. Deep also will be there after some time. Dr. Belinda Jaj from St. John's, Bangalore. Dr. Saumik, professor from Kolkata. Dr. Mangraj from Bhubaneswar. So these will be the faculty members who will be assessing you in the next 12 to 24 hours. And without wasting much time, we shall first do the lamp lighting and then we will start off the presentation. I request all the faculty members to please come and do the lamp lighting as customary for any educational event.
या कुन्देन्दु तुषारहार धवला या शुभ्रवस्त्रामृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतं शङ्करं प्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेष जाड्यापहा
Correct. Research. Okay. Perfect. All of you are ready? No, Josh? Not heard. Very good. Dr. Ankit, floor is yours.
Good afternoon, respected judges and all my dear colleagues. I am Dr. Ankit Manglunia from IMS in some hospital, and I am going to present my research proposal for the topic on clinical and biochemical predictors in early pregnancy for development of gestational diabetes. The global prevalence of gestational diabetes has been progressively rising, and currently the South Asian countries bears the most of the burden around the world. In India, it is believed that Indian women have 11-fold increased risk of gestational diabetes, and the current prevalence is around 15 to 20%. It is not only associated with the immediate adverse fetal-maternal outcome, but there are also long-term implications, like there is increased risk of type 2 diabetes and cardiovascular disease, both in the neonates as well as the mother. Over the last 2 decades, the prevalence has risen progressively. In earlier 2000, it was nearly about 5 to 7%, but now it has increased to 15 to 20%. Based on the different diagnostic criteria that are used for diagnosis of gestational diabetes, the prevalence is different across different states in India. It is considered highest in Punjab as well as the Uttar Pradesh, amounting to 35 to 40%, whereas in few states like Rajasthan, it is only around 5 to 6%. So currently, only on the basis of clinical risk factors like obesity, BMI more than 35, or family history of diabetes, or PCOD, the yield is poor. It is around only 60% we can detect the rate. There is higher risk of 30 to 40% having high false negative rate on the basis of the only clinical risk factors. The best method for identifying women in early pregnancy at high risk of GDM is still unclear, and there is no international consensus which is the preferred approach or testing approach should be followed. Around 70% of the patients after being diagnosed at 24 to 28 weeks can be managed only with the lifestyle modifications. Basically, simply controlling their diet and splitting the meals can control the blood sugars level. So keeping this in mind, if we are able to predict which pregnant woman will be diabetic in the earlier stage, we can have the interventional modifications like lifestyle or behavioral modifications in the earlier part of pregnancy, so that we can have decreased complications later on. So my primary objective for the thesis is, for this research purpose, is to develop a predictive scoring system which will utilize the anthropometric, glycemic, and inflammatory parameters in the early pregnancy for prediction of later development of gestational diabetes. My secondary objective that I want to look for is to identify these early trimester inflammatory and hormonal parameters and to look for their associated with the adverse fetal-maternal outcomes. So my research design will be a prospective observational cohort study which will enroll pregnant women of less than 14 weeks at their first antenatal visit. The biochemical and the anthropometric measurement will be done for every woman, and those who will get diagnosed as GDM will be compared with the normal glucose tolerant women throughout the pregnancy. The time period for my study is for 2 years, which consists of 15 months of recruitment of the patient and 9 months of their follow-up. The sample size, keeping in mind the 10% dropout rate and 19.8% prevalence in our institute, was calculated to be around 1350. The inclusion criteria in my research project will include all pregnant women above 18 years with singleton pregnancy visiting the hospital in their first antenatal visit. The exclusion criteria will consist of multiple pregnancies, those who are known case of diabetes or had GDM in their last pregnancy will be excluded. Patient having pancreatic disease will also be excluded, and the patient who have been diagnosed as impaired glucose tolerance or diabetes on their first OGTT test after their inclusion, they will also be excluded. We are also looking at a thyroid parameters as a predictor of GDM. So those patients having history of thyroid disorder, whether hyperthyroidism or hypothyroidism, history of thyroid surgeries or any thyroid carcinoma will be excluded from my study. So basically, I'll be looking at few of the risk factors like family history of cardiovascular disease, hypertension. Then I will look at anthropometric measurements, which will be taken at neck circumference, mid-arm circumference, thigh circumference, and waist circumference. Then mainly I will look at the multiple biochemical parameters, which will include oral glucose tolerance test, serum insulin, thyroid profile and anti-TPO antibodies, lipid profile, HbA1c, serum uric acid, sex hormone binding globulin, and an inflammatory marker HSCRP. I would also like to look at 3 of the novel markers, which consist of fertuin A, tumor necrosis factor alpha, and glycated CD59. Whenever the patient visits for the first antenatal visit, we'll keep the sample in the fasting state and will store it at -80 degrees. Now, I'll like to propose my expensive budget plan for my thesis. It will consist of recurring staff, mainly the nursing staff and the data operator, who will be required to collect the samples, maintain all the records, and keep a close follow-up for the patient. There will be few consumables, but the major budget which will be cost is for the reagents, which will amount of nearly 19 lakhs 28,000. Overall budget for my research proposal would be around 25 lakhs. So to summarize my plan, the patients visiting at the first antenatal visit will be screened. Their anthropometrical and biochemical parameters will be taken. Samples will be collected in fasting state and will be stored at -80 degrees. They will be prospectively followed up till their delivery. And those patients who get diagnosed as GDM will be matched in 2:1 ratio with the controls, with same age and BMI matched controls for the final analysis. Thank you.
Nice presentation, Dr. Ankit.
Thank you, sir.
You said that the glucose criteria for the first visit will be excluded. Do you mean that sample collected during the first 3 months will be excluded? Or even if first visit falls after 3 months, you will like to exclude that data?
I didn't get
You said somewhere that the first visit data will be excluded. Why are you thinking
Yes,
so?
sir. I said that if on the first visit, patient will be undergo oral glucose tolerance test. If the sugar levels are above the limit, like fasting is above 92, or 1 hour is above 180, or 2 hours is above 153, we will exclude those patients.
You will not include,
You will not include,
thinking
sir.
that they will be having pre-gestational diabetes.
Because we have to look for the risk factors who will become diabetic later on.
So
after
even if they are developing, their first visit is lying within 3 months of pregnancy, or
Sir,
even
less than
thereafter.
14 months. Less than 14 weeks.
So probably you have not specified that.
Sir, I have specified 14 weeks of pregnancy.
Then I overlooked that.
Okay, thank you. Good presentation. What I wanted to know is what is the expected outcome of your study?
So according to the literature which I have seen, so all these parameters are nothing new apart from this fertuin A and glycated CD59. But the research has been controversial. Like HbA1c, it has shown if HbA1c is more than 5.7, then there is 3 times odds ratio of having diabetes. Whether HbA1c is 5.2, then odds ratio of developing diabetes is around 1.6. Whether few studies have said that HbA1c has no role. Similarly, like with thyroid profile, if we looked in, the Indian study was done by Dr. Agarwal in 2017. There was no result of thyroid profile. But whereas in few studies, it has been seen that FT3 and the anti-TPO have close association with the development of gestational diabetes. That has been seen.
So you should derive a scoring.
So, sir, everybody has done 2 or 3 parameters. So, what I am doing with this key, whether these association can have a predictive scoring, like we have a score for rheumatic fever. Similarly, we can have a major or minor criteria. If I can develop a score that will help to predict GDM, and those patients can have a close watch.
Yeah. What is the reason for excluding previous GDM?
So, because we are looking for patients who will become diabetic later on. If they have a history of previous GDM, then they are already at a higher risk of having diabetes.
So I don't see a reason why you should exclude them, because they are going to give you more information about the prediction score will be better.
If they had a previous GDM, then they are already at a risk of higher insulin resistance. So most of the parameters that I'm looking, these are the marker of insulin resistance.
Yeah,
so,
but you're trying to look at the prediction of GDM only.
yes,
And a woman who has had previous GDM has got a very high risk, and all these predictive factors are going to be strongly present in her, and that is going to predict give a good prediction.
Looking at it in another way, if someone say has a low risk for GDM, then do you propose not screening that person for GDM?
Sir, universal screening is mandatory.
So how does your study help?
Yes. Yeah, the point is, supposing everybody was to get screened once in each trimester, would that not be more economical and more sensible from a health?
Sir, that will be an economical. So what I propose is these novel markers are really costly, like this fatty and glycated CD9, which is not even available most of the places. I am doing a large prospective study, so I will also want to look scientifically about these novel markers. But
you
for the
are-
predictive scoring,
you have already ruled out one of the major causes, which is previous history of GDM. Then that way, if you say that previous history of GDM is a sign of insulin resistance, then obesity should also be ruled out. So anybody with the
Sir,
BMI,
so that is why I have taken controls who have age and BMI matched. Only those controls I will be.
the point is that the same logic that you are giving for excluding previous history of GDM, the same logic will be applied to BMI. I just have one friendly suggestion. Just look at the references that are used. You have used 2017 ADA. Ankit, this is 2022 now. 5 साल हो गए. अच्छा, वो भी मैं मान लूं, कुछ ना कहूं, but एक बार दिखाओ तो सही अपनी slide. Abridged for primary care practitioner. बता तो DM endo है छोटे भैया. तुमने वो देखी ही क्यों ये वाली 2017 abridged for primary care providers? Why on earth did you even go to read that document? Why did you not read the proper standard of medical care? And why not 2022? So अगर 2012 और 2017, if you are going to use references from 2012 and 2017, and then in 2022 you will ask for 25 lakh rupees. It doesn't make sense.
Just one last.
Right, and also sugar and if anybody else is going to use the word sugar ना, तो मेरे से खाओगे तुम दो. All the boys, तो मैं सच में कह रहा हूँ. You know what that means?
It's important.
दो
You should
खाओगे.
always use the term.
हाँ, anybody who uses the word sugar, all of you throughout your professional careers, मैं तुम्हारे सपने में आऊँगा. और बहुत गंदे तरीके से आऊँ. ठीक है? So what is the difference between sugar and glucose? Then we stop this viva.
The sugar is a layman term.
No, what's the chemical? बताओ. Is it H2O or is it what?
So C6H12.
Tell. Come on.
C6.
Sugar. Huh?
C6.
Are all sugars
H11OH.
glucose or is all glucose sugar?
Yes, a glucose is basic, but fructose and galactose are all sugars.
So in tomorrow's viva, whenever the next chance comes, you will tell us about sugar versus glucose, right?
Just one last technical question regarding statistics. Which statistical test do you plan to employ to get a risk score predicting GDM?
Sir, I will do the multiple regression analysis first, and we'll look at the independent parameters which have a very high
You are
odds
putting
ratio.
together independent parameters, getting an equation or something. Then what are you going to look at?
So then I will use an R statistical software to formulate a normogram.
Area under curve or something to get the discriminant score. Anyway, take it. Okay, well done.
Thank you, sir.
White screen, not square. White screen. Should be a white screen. Not yet. Okay.
Should I start? Okay. Good afternoon, respected teachers and all my fellow participants. For today's grant proposal, the proposal I'm presenting is to assess the role of preoperative zoledronic acid in the prevention of hungry bone syndrome in primary hyperparathyroidism, a randomized controlled trial. So the incidence of primary hyperparathyroidism in India is about 6 per 1 lakh person years with a female preponderance, and majority of them are young age. And the mean duration of symptoms before they present to us is very high. And the main modality of treatment or the primary modality is surgery for these patients. Hungry bone syndrome in India is not an uncommon post-operative complication. In Western literature, it is around 10 to 14%, from Saudi Arabia around 4%. But in India, we have the incidence rate between 24 to 80%. So it's not very uncommon. So the predisposing factors which were seen and presented in the endocrine journal, European Journal of Endocrinology, were higher burden of disease before the operation and a large volume of parathyroid adenoma, which has been resected in these cases. I'm talking about adenoma here. So how to tackle hungry bone syndrome? Obviously, the first modality to counter that or to reduce the prevalence would be early diagnosis and surgery. It has also been seen that vitamin D supplementation also helps in decreasing the incidence, and there is a possible role of preoperative anti-resorptive agent use. So the evidence for anti-resorptive agents, it has discordant outcomes. There are certain beneficial effects seen by certain low quality trials, which mainly being case reports and case series for pamidronate. Also for zoledronate, they have seen certain positive studies. For example, a retrospective case series from Saudi Arabia, and we have our Indian data. However, it is retrospective in nature, which are poor quality designs. However, there are other case reports which have shown there is no benefit. So overall, the evidence is controversial. So coming to the post-operative bone health in patients who have undergone surgery for primary hyperparathyroidism, the Horizon trial for postmenopausal women, they showed that bone turnover markers start reducing significantly after 3 months of giving a single IV dose of zoledronate. In primary hyperparathyroidism, after curative surgery, it is seen that the trabecular bone mass increases rapidly after the first 3 months of surgery, and it is sustained up to 10 years. However, there is a lesser improvement in the cortical bone mass accrual. Also, it has been seen that zoledronate versus placebo, a recently randomized controlled trial published last year in the EJE, showed that there was a sustained gain in lumbar spine and neck of femur bone mineral density gain in zoledronate acid group at the end of 1 and 2 years. So coming to the knowledge gap for which I'm presenting this is, what is the true incidence of hungry bone syndrome in India? What is the effect of anti-resorptive therapy on prevention of hungry bone in patients who have been surgically cured? And what is the effect of BMD accrual after 1 year of successful surgery in patients who have received zoledronate prior to operation in Indian population? So we hypothesize that patients who received preoperative zoledronate have a lesser incidence of hungry bone syndrome. Furthermore, these patients will have greater BMD gains at the end of 1 year post-surgery. The objectives are similar. So the outcomes are, primary outcome is to assess the rates of hungry bone syndrome in primary hyperthyroid subjects who underwent successful parathyroidectomy. Whereas the secondary objectives are to assess the BMD change as well as to look at the change in the bone turnover markers at the end of 1 year post-surgery. Coming to the inclusion criteria, here I have taken premenopausal women and men aged being 18 to 45 years who have an identifiable single parathyroid lesion on imaging confirmed by FNA IPTH. And we have the indications for surgery, which are already well known. Coming to the exclusion criteria, we have menopause women, people who are on calcium mimetics or lithium, diagnosed cases of FHH, people who have CLD, underlying active malignancy, or conditions known to affect the bone mineral density. Furthermore, CKD, where the eGFR is less than 35. Also, those who have already received anti-resorptive therapy have been excluded from the study, as well as those who are about to undergo a dental procedure. Coming to definitions, hungry bone has been defined as a persistent hypocalcemic state after day 4 of successful parathyroidectomy with one of the following: low serum phosphate, low serum magnesium, normal or raised IPTH, and low 24-hour urinary calcium in spite of adequate calcium supplementation. Coming to the study design, I have given the overall here that the diagnosis of primary hypothyroidism has been diagnosed with a single lesion, either with a sestamibi SPECT CT or a 4D CT and confirmed with the FNA IPTH. After this, we would ask for approval from the CTRI, and the CTRI would randomize the patients to receive either IV zoledronate or placebo. Both arms will receive adequate 25-hydroxy vitamin D supplementation. After surgery, we will assess for the calcium, phosphate, alkaline phosphatase, as well as albumin from day 0 to day 7. Day 4 onwards, if the subjects have hypocalcemia, we will do further evaluation in the form of magnesium and 24-hour urinary calcium to look for hungry bone is there or not. After discharge, we will also look at the days after which the patient has been discharged after parathyroidectomy. Patients will be on calcium and vitamin D supplementation post-discharge. There will be further visits at visit 3 at 3 months and 6 months. However, BMD and bone turnover markers will be seen at the end of 12 months post-surgery and prior to surgery, just before randomization. We are also looking at the baseline BMD as well as bone turnover markers. Study duration is 5 years, 3 years for recruitment. Last recruitment will be end of 3 years. 1 year we'll finish at 4 years. In the 5th year, data analysis, and we'll send for publication. Variables for data collection, as I've already mentioned, but to specify, we will use IPTH and we will use serum PINP and CTX. Also, we will monitor for severe hypercalcemia, and we will do imaging, which includes DEXA scan, 4D CT, SPECT CT. Coming to sample size, I have used a previous study from India, which showed a retrospective study, and we used the modified Kelsey formula to look at the sample size, and we are getting 23 patients in each group, adjusting for attrition, 25 in each group. For analysis, we are using intention to treat. The baseline statistics, we are using chi-square to look at whether any confounding is present. Crude association is looked at all the variables, and the crude OR has been calculated. The crude relative risk will be calculated for the primary outcome. Now for the adjusted relative risk, we will look at multivariate logistic regression, where the independent variable is presence or absence of hungry bone, dependent of variables being treatment arms, and those covariates which we have found to have a crude association with hungry bone syndrome. Here we will calculate the number needed to treat. For the secondary outcome, we are looking at the change in BTM as well as DEXA. Finances per patient for the project supervisor will take around 7 lakh rupees per patient. Total of 33,000 will be there for all the investigations, and for the treatment, if required, coming to around 30 to 31 lakh. The conclusion would be, since this is a condition with significant morbidity, hungry bone reduction would be beneficial, and this will be answered by this study. And if we have a significant relative risk reduction and a low number needed to treat, this will be possibly included in the future guidelines. Thank you.
Which bone turnover markers will you use?
So CTX and P1NP.
What's the difference between both?
Sir, P1NP is a bone formation marker, whereas the CTX is a bone resorption marker, sir.
How frequently will we check them?
So baseline and at end of 12 weeks. Baseline, that is before surgery, and at 12 months after surgery, sir.
So you finished well ahead of time.
Sorry.
Congratulations for that. So we'll get more time to ask you questions.
Okay.
Anyway, so
Hungry judge syndrome.
So what's the title of your study?
Assessment of incidence of hungry bone syndrome in patients who are receiving zoledronate or placebo.
Okay. So why did you choose zoledronic acid, and why didn't you choose, say, denosumab or say alendronate or risedronate?
Sir, I have not used denosumab in these patients because it has been seen that after cessation of denosumab, there is a rebound increase in bone resorption, which is, I would admit, seen in postmenopausal women. Also, there has been a recent concept that denosumab increases the formation of osteomorphs, which are hibernating osteoclasts, which revert back to osteoclasts after cessation of denosumab. So I did not want to use this because data is lacking for primary hyperparathyroidism. It might be unethical to give these patients this, and if they have an increased incidence of fracture, that would be unethical.
So you spoke of doing an FNSE IPTH.
Yes, sir.
Before proceeding. So is that standard of care?
Sir, I am doing this because I want to confirm these patients before I randomize, because it has 100% specificity. So I'm using that to confirm these patients.
And you spoke of doing a intention to treat analysis.
Yes, sir.
So in your study where you are giving a single dose of zoledronic acid,
Yes, sir.
will it make a difference if you do a per protocol analysis?
Sir, if they are lost to follow up because of any reason other than treatment, so then I would still stick to ITT.
Treatment is a single time event here.
Sir, but follow up, that is for the secondary objective. Not for the primary, it wouldn't affect me, but for the secondary, it would still affect me.
And you're working in Kolkata, right?
Yes, sir.
So where do you propose to do a 4D CT scan?
So we do it in our institution.
You're doing it?
We are doing it, sir. We have done for 3 patients. We have got 2 concordant results, 1 discordant, but that 1 discordant had sestamine B negative as well, and she is on cinacalcet.
What are the good presentation?
Thank you so much,
And a good topic. What are the possible confounding factors that you are likely to encounter in your study?
Ma'am, some of the confounding factors I have already excluded. That is number 1, postmenopausal women. Number 2, hyperplasia or double adenoma. I have tried to remove those. The other thing is that in India, inherently, we have low BMD, so that might be a confounding factor, but I have tried to remove the confounding factors by a multivariate analysis, looking at all the crude odds ratio for all the independent factors which we are looking at for hungry bone. I have tried my best, but still there might be some confounders.
In your sample size
Yes,
calculation,
ma'am.
what percentage of hungry bone syndrome have you taken from literature?
Ma'am, I have taken difference of proportion based on the Indian study by Sarati et al. In that they had looked at a retrospective study of 19 patients in which 11 received zoledronate and 8 did not receive zoledronate. Out of 11 who received zoledronate pre-op, 0 had hungry bone, and out of 8 who did not receive, 3 had hungry bone. So the incidence of hungry bone is 37.5%. Based on that, I have calculated my sample size.
How you intend to randomize your sample?
Sir, for randomization, I will ask the Clinical Trial Registry of India and I will ask their guidance for it. I do not want to propose anything before what they tell me. I want them to tell me how to proceed for randomization.
How
Just remember, nobody will tell you. You only have to propose.
that is for
Sir,
ethical consideration.
I have added the finance for a supervisor, so I would leave.
No.
Yes,
I am
sir.
asking how do you intend to randomize?
Yes,
Means for ethical concern, you are leaving it to them.
Yes, sir. I left it for them. If they say I have to do it, then I will come up with a computer generated software. But I won't do it. I computer generated software.
I think you can propose. They might disagree, but
Yes, sir.
leaving on them to
A
propose
simple
how it should
computer
be done.
generated algorithm for it, sir. Not consecutive patients, because that would be unmasked later on. So computer generated randomization. Sir.
Is there any way of doing a blinded study?
Sir, here I am blinding it by only the supervisor would know. The caregiver, that is me or the other doctors involved, or the patient would not be knowing. So anyway, I'm trying to make it a double blinded. Only the supervisor will know what is being given here, sir.
How it is double
I
blended?
will
then?
repeat that.
How it is
again.
double blended? then?
What is double blind?
So double blind is the patient, the treating doctor does not know, only the person who is managing the data knows. Triple blind will be when the person who is supervising or managing the data also doesn't know, that will be triple blind.
So you will give maybe a normal saline infusion?
Yes, I'm giving a normal saline, sir. Yes, sir. I have mentioned that. I placebo plus 25 hydroxyvitamin D. I'm giving.
So nice presentation. Just a small suggestion. In your review of literature slides, you have put in certain reference numbers.
Sir,
So it's better to keep them at the bottom of the slide.
it would become a little crowded, sir. A little too busy, sir. I tried.
Nice.
Sorry.
Hormones behaving right now.
Would be a slightly higher side, sir.
So you won't get any marks for the last question.
How do we optimize that?
Thank you, sir.
Good evening, respected judges and my fellow participants. I am Dr. Devaditya Das. Today, I'll be presenting my grant application in PowerPoint format, and my study is serum irisin as a first trimester biomarker for predicting gestational diabetes mellitus. So, GDM is a first diagnosed diabetes during pregnancy, defined as an abnormal glucose tolerance in various degree that may result in negative outcomes for mothers and their fetus and newborn. And we have seen that over the past few years, there is a gradual upward trend in India. A recent study in North Indian population even showing a prevalence up to 35% using the WHO 2013 criteria. So it is GDM is of public health priority, and it is of utmost importance that we identify potential predictors of glucose intolerance in the pregnant population. In this regard, irisin is a novel myokine and adipokine that induces an increase in total body expenditure and improves insulin sensitivity and glucose tolerance in humans. There have been several studies that have reported that there are reduced irisin levels in women with GDM or in those whom GDM was later developed, compared to those who did not develop GDM at all. This is a cartoon showing how the myokine and adipokine irisin works in our body. So coming to the rationale of this study, why is this study needed? As we know, as per most of the guidelines, GDM is diagnosed at the end of second trimester by elevated blood glucose values when fetal damages by metabolic and epigenetic changes have already started. And as a result, treatment cannot be started before the late second or third trimester when the process of high risk of fetal damages have already set in. So if by any method we can predict development of GDM in the earlier part of pregnancy, it can avoid many disasters induced by GDM. As discussed in this regard, novel myokine and adipokine irisin has shown some promise in recent studies as a potential biomarker for predicting GDM. However, there are no data regarding the irisin levels and how it relates to GDM in the Indian population. And as we know, irisin primarily is secreted from the muscles due to exercise, and given our unique body composition, the utility of irisin as a biomarker for evolving GDM in Indians needs to be investigated. This is my research question. Can first trimester maternal irisin level differentiate Indian pregnant women who develop gestational diabetes mellitus from those who don't? And my hypothesis is that irisin levels can help predict the future occurrence of gestational diabetes mellitus. So my primary objective is to obtain a cutoff level of serum irisin from maternal blood in the first trimester for predicting later occurrence of gestational diabetes mellitus. And also secondary objective is to assess the association of maternal irisin level with baseline HOMA-IR of the patients. What can be the impact of this research? So early prediction via my biomarker can help us stratify the high-risk pregnancies for evolving GDM, and we can act faster, resulting in lesser occurrence of fetal-maternal complication. As we know, as per Barker's hypothesis, by taking early care of the metabolic derangements in the mother, we can actually cut down the possibility of the future metabolic derangements in the offspring. And this project in the long run may be able to provide some mechanistic views regarding the evolution of GDM. Coming to the methodology, my inclusion criteria is are Indian pregnant women with no prior history or evidence of diabetes mellitus, and pregnant women in the exclusion criteria, pregnant women having any kind of history or evidence of prior any kind of any type of diabetes will be excluded. Also, mothers with multiple pregnancy, chronic hypertension, and pre-eclampsia, etc., they will also be excluded from the study. The study will be conducted in the antenatal clinic of IPGMER. This is a nested case control study, and the study will start from March 2022, and proposed ending is on February 2026. These are my study parameters. Detailed history will be taken according to these points, and physical examination will also be done at baseline and also at 24 to 28 weeks, and certain laboratory parameters will be measured at baseline and 24 to 28 weeks. I'll just skip over the laboratory analysis part due to time constraint. This is the formula I have used to calculate my sample size. By using the above formula for and taking an approximate prevalence of GDM as 10%, sensitivity of maternal irisin levels of 540 nanogram per ml or more, of sensitivity of this level to be 82% and a specificity of this level to be 89%, we'll be needing at least 845 patients with diagnosed GDM and 90 matched patients without GDM. So coming to the study technique, how we'll conduct the study, enrollment of patients will be done between 6 to 8 weeks, 6 to 11 weeks of gestation. At the first visit, history checking, physical examination, and blood collection, etc., will be done. And except for serum irisin and fasting insulin levels, all the bloods will be analyzed then and there. And for irisin and fasting insulin levels, the blood will be stored in aliquoted plasma at -80-degree freezer. And again, blood collection will be done at 24 to 28 weeks of gestation, and serum samples of irisin will also be taken. And then diagnosis of gestational diabetes will be made according to the WHO 2013 criteria, and patients will be divided into two groups, that is patients with GDM and patients without GDM. And after the patient recruitment will actually stop once required number of patients with GDM and match controls are obtained, and then the irisin levels and fasting insulin levels samples that were stored will be analyzed according to the selected patients, and data analysis will follow. This is my budget summary that I propose. I'll be needing a total of 29,11,000 rupees, which consists of cost for manpower, consumables, travel and contingencies, and a 10% overhead cost. These are my references. Thank you.
Irisin you will check twice, right?
Yes, sir.
What's the normal value of irisin?
So normal value ranges from 30 nanogram per ml to up to 720 nanogram per ml.
Is there a difference between men and women or according to age or according to weight?
Yes, sir. There is a difference. According to the mainly, it is how much calorie he or she is intaking, how much is the muscle mass, and also the gender difference also plays a role in the irisin level. This the value I told was seen for pregnant mothers, the range that I told.
You mentioned one place, I'm not sure if I got you. You said you will do BMI twice also. Body mass index, you will check at 24 to 28 weeks.
So the BMI and anthropometry, I'll check only once.
Yeah, so I was not very clear about that. See what you write. How do you check body mass index at 24 to 28 weeks of pregnancy?
That will be an issue, sir. The BMI part I won't be checking. So
What
I
do you
will
check
check
in a normal pregnancy? If you cannot check body mass index, what do you check?
we can check the neck circumference or maybe wrist circumference.
Suppose you are an obstetrician or a primary care physician. What will you check? In
I'm
all
not
the
sure.
baroanthropometric measures, what is that measure which has maximum impact on fetal outcome and also on long-term metabolic outcome? Is it body mass index of a pregnant woman? Is it weight? Is it any longitudinal change? Try to answer
The
this
amount of weight gain that the mother has had
question.
with
So who's going to write that?
the yes, sir.
क्या लिखोगे आप बताओ? Tell me the exact English. What will you write?
I'll on the first prenatal visit I'll record the weight of the mother and then
And the BMI.
and the
Which
BMI
is
also.
fine. Pre-pregnancy BMI. Okay.
Yes, sir.
And then what will you check at 24 to 28 weeks?
Again, I'll check the weight of the mother and how much the mother has gained.
Yeah.
And
So what do you call that? How much the mother has gained? Give me one phrase for that. Like in pediatrics, what do you check?
Obstetric weight gain.
No. Nahin. What do you check in children when you do a growth charting twice?
We check the weight gain and height gain velocities and
Shabash. So,
Dash
tell
weight
me the
gain.
proper English.
Yes.
I won't let you go until you
Dash
do
weight gain. Dash pregnancy weight gain.
Post pregnancy weight
that. Yeah, just weight gain. That is it. Yeah,
Yeah.
or weight velocity or whatever.
So I just have a few questions. You propose to measure the irisin a second time. How is that going to help?
My primary objective is to see whether I can get a cutoff level in the first trimester only,
The
and just
second
to the second one is just to address to some secondary objectives how it is changing
that
or not.
brings me to the cost of consumables. Can you just go to that?
Yes,
part?
sir.
So you propose to store your samples. So
Yes, sir.
what is your consumable cost in the first year for?
Sir, I'll store my sample, the consumables like buying a
Syringes.
refrigerator and
So
like all these things, minus 80
Propose to buy a
refrigerator.
refrigerator, okay. And okay, it's good to know. So you spoke about the Barker's hypothesis. What
Yes.
exactly is the Barker's hypothesis?
Barker's hypothesis state that most of the metabolic problems that we have in the childhood, adolescent, and then adult years, the seed is actually planted in the mother's womb
is
only.
it related to hyperinsulinemia or IUGR? Or what is the Pedersen hypothesis? Have you heard of it?
Yes, sir. The Pedersen hypothesis tells that basically the due to the hyperglycemia in the mother, the glucose actually crosses via the placenta into the fetus, and that hyperglycemic levels can increase the insulin.
That will possibly be more at play here.
Yes, sir. That also. Yes, sir.
And when you talk of any risk marker for predicting a future event, there is a term called calibration. Are you aware of it?
Yes, sir.
What does it mean?
Basically, it means that fine tuning and finding an exact level that is ideal and has a best sensitivity and specificity ratio and a high area under curve when we're doing a ROC
Area
value.
under curve is discrimination. Calibration is somewhat different. Anyway, well done. Nice presentation.
Thank you, sir.
One last question, Dr. Devditya. You mentioned that your study is a nested case control
Yes,
study.
ma'am.
Can you just elaborate what is a nested case control study and what is your study a part of?
Yes, actually, although it has the word nested case control in it, nested case control is actually a mixture between case control and cohort. And in case control, what we do is we start with the disease and then go back to the cause of the disease. But in this case, actually, we are doing a prospective study where the disease has not manifested itself yet. It will manifest in the future, and when it does, we'll then group the participants into two groups and then analyze like a case control study. So it's not that the case and controls are already there to begin with, but they will emerge later. And when they emerge, they will go back and analyze like a case control to see whether that factor where what we are analyzing, in this case irisin, is different in both the groups or not.
What is nested? What is the word nested then? And what is your study a part of?
The last part I couldn't hear, ma'am.
Your study is a part of another larger study?
No, ma'am. Nested case control is basically when the case and control definition, the cases hasn't occurred yet. It will occur later, and doing that, we'll again go backwards and analyze. That is the mixture of case control and cohort. This is called a nested case control. It's not like it is a part of a bigger study. It's not like that, anything like that.
So you're not nesting on anything. So when you say
No, ma'am.
nested, it has to be part of a larger cohort study. You cannot call this a nested case control study.
What is the weight gain up till 24, 28 weeks of pregnancy? Normal weight gain.
Around 15 kgs. Sir.
Are you married?
I am.
चलो ढूंढ के बताओ आंसर and वो भी before Tysa finishes you have to guess the answer, sugar versus glucose, and your answer is weight gain in normal pregnancy first, second, third trimester. That is your question.
Sure,
You will not leave Hyderabad without sharing that information with all of us.
So there are a lot of other causes as risk factors for PCOS and stress, all those things. How will you compare?
Other risk factors for sir? GDM.
PCOS.
So my idea is to, when I'm selecting my patients of controls, my idea is to do a propensity score analysis by SPSS software and do a matching of all those confounding factors that might be there so that I can eliminate it or balance it in both the groups. No, sir, I didn't mention this, but so it's matching.
Because
because of restriction of time, I
IT
could.
professionals, it is very common. GDM.
Yes, sir.
Why have you chosen irisin? There are lots of markers in biomarkers available. So does this biomarker or myokine has a very high positive predictive value or
Compared
negative
to,
predictive value? So
yes,
why
sir.
you have chosen this single parameter only?
I did a literature review, sir, before thinking about this, what topic to choose, and I saw the recent studies are there, which is showing that irisin is coming up as a really promising biomarker on its own with a high sensitivity and specificity. And there have been many studies throughout the world, but none in India. So that is why it stuck to irisin, because taking a lot of biomarkers will again not be very practical. Even if I take a lot of biomarkers and then try to predict via that, and later converting that to commercial practice, it will be very cumbersome. It will be better to just do a FBS, PPBS maybe, 2 hour OGTT maybe. That's why I stuck to just one better biomarker which can help me predict.
The data is less robust with regard to irisin level.
Have you heard of metabolomics? And do you think it is relevant in this setting?
Yes, ma'am, it can be relevant. Metabolomics is actually the set of a lot of metabolite levels, which can, or a, so to say, a pattern or a signature of metabolic, so to say, a metabolic signature, which can actually predict a lot of diseases. And in GDM also, it can be of help, metabolomics, proteomics, etc. FBG, sir. FBG.
Is there any studies to compare with that OMA or the insulin versus all those things?
In GDM, I couldn't find any such studies, sir. But in type 2 diabetes and in also healthy controls, there are studies which actually shows a correlation of irisin, HOMA, IR, etc. The higher the levels of irisin, the less the insulin resistance.
Higher the irisin, the better it is.
Yes, sir.
Yeah. So in all these glycemic parameters that we have, like fasting glucose, post-challenge glucose, insulin, usually higher is worse, right?
Yes.
Can you think of any other glycemic parameter which is better if it is lower? And this is used for monitoring a particular type of glycemic control. Yeah, yes. So like fasting glucose, better is lower. Yeah, no. So, better is higher. Yeah, that's what I wanted to ask. Yeah. I put the
Higher
question
the
wrong.
parameter, value of the parameter,
Yeah.
the better is
Yeah,
glucose
equivalent
control.
is like supposing HbA1c is very high, you are happy.
I would say
Yeah.
time in range.
That's good. That's right. Anything else? That's good. For postprandial hyperglycemia.
I'm not aware, sir.
You will find out and let us know. Yeah.
Thank you, sir. Thank you.
You got 2 homeworks now.
Good afternoon, respected judges and my dear colleagues. I am Dr. Hashita, and for today's grant proposal, the topic I have chosen is prevalence and predictors of sarcopenia and sarcopenic obesity in type 2 diabetes mellitus. Coming to a brief introduction about what is sarcopenia and sarcopenic obesity. Sarcopenia is defined as age-related loss of muscle mass plus low muscle strength and or low physical performance. And this definition has been taken up from the Asian Working Group for Sarcopenia Guidelines 2019. And sarcopenic obesity is defined as sarcopenia and obesity occurring together in the same individual. Both these parameters are equally important because they are associated with poor health outcomes such as cognitive impairment and functional decline, depression, falls, and fractures and mortality. Coming to the topic of sarcopenia and diabetes, they both share a bidirectional relationship. Individuals with diabetes are more prone to develop sarcopenia. Some of the studies have quoted that they are at 3 times the risk of sarcopenia, whereas individuals with sarcopenic obesity are more prone to develop type 2 diabetes. And there are studies to show that they are at increased risk of atherosclerotic cardiovascular disease. Moving on to the topic of prevalence of sarcopenia, there is a meta-analysis already. This meta-analysis has quoted that the prevalence of sarcopenia has ranged from 6.3 to 47.1%, and the pooled prevalence of sarcopenia was 18%. However, majority of the clinical trials that were included in this meta-analysis were from Caucasian population with underrepresentation of Asians. And in the fewer studies that were from Asia, it was mostly the European guidelines that were used to define sarcopenia. And a recent meta-analysis where they have tried to analyze the prevalence of sarcopenia worldwide. Contrary to what is the normal belief, it is shown that the prevalence of sarcopenia is higher among non-Asian individuals than Asian individuals. And this could be because we were earlier applying the criteria of Europeans to Asian individuals. to diagnose sarcopenia. Hence, applying ethnicity-specific cutoffs helps to avoid over-prediction of sarcopenia in Asians. But still, majority of these studies did not, there was underrepresentation of data on the prevalence of sarcopenic obesity in these studies. As Asians, as an ethnic group, we are more prone to develop visceral adiposity compared to our Western counterparts. Knowledge of prevalence of sarcopenic obesity along with sarcopenia is equally important. There is one study from Chandigarh called CUBES, which has seen at the prevalence of sarcopenia in a community setting in healthy individuals, where they have excluded individuals with type 2 diabetes, and they have developed Asian cutoffs for development of sarcopenia as well as sarcopenic obesity. Apart from this, I could not find any major major articles on the showing data on the prevalence of sarcopenia. And there is data so far on the burden of sarcopenia and sarcopenic obesity in individuals with type 2 diabetes is very less explored. And also the factors that might be associated with sarcopenia as well as sarcopenic obesity are scarce. I would like to, through the study, I would like to understand the prevalence of sarcopenia as well as sarcopenic obesity in type 2 diabetes mellitus and their associated risk factors. The objectives are the primary being the to study the prevalence of sarcopenia and its sarcopenic obesity in individuals with type 2 diabetes, and to study the predictors of sarcopenia and sarcopenic obesity or the associated factors of sarcopenia and sarcopenic obesity in the same individuals. This will be a cross-sectional study in a hospital-based setting, and the study duration is of approximately 2 years, wherein individuals with newly diagnosed type 2 diabetes between the ages of 40 to 70 will be included after obtaining informed consent. The reason why I've taken newly diagnosed diabetics is because a lot of OADs as well as insulin will have an effect on the sarcopenia status, muscle mass status of the individual or the adiposity. Hence, I prefer to take up newly diagnosed diabetics. Their socio-demographic data, other associated comorbs, micro and macrovascular complications will be noted, and their physical activity will be estimated using IPAC questionnaire. And the daily protein intake and total calorie estimation will be done by a 7-day recall method. Anthropometric measurements including height, weight, BMI, waist-hip ratio, and calf circumference will be noted. And appendicular skeletal muscle mass and fat mass will be estimated by DEXA. Hand grip strength of the dominant hand will be measured using a handheld dynamometer. And as a part of the assessment of sarcopenia, physical performance of the individual will be assessed by a 6-meter walk test and 5-time chair stand test. And to classify the individuals into various groups, that is sarcopenia and sarcopenic obesity, I'll be using the Asian Working Group Guidelines on Sarcopenia 2019. After recruitment, I would ideally like to classify them into 4 groups. The first group is where only sarcopenia is there with a normal BMI. The second group being sarcopenic obesity. And the third is only obesity without any evidence of sarcopenia. And the last group is where neither sarcopenia nor obesity is seen. And after an overnight fast, I would like to do the following investigations, that is hemoglobin, creatinine, bilirubin, liver function test, serum albumin, total calcium, fasting blood glucose, glycated hemoglobin, TSH, and an ATM testosterone and 25-hydroxy vitamin D. As already discussed, I would like to include newly diagnosed type 2 diabetics as per ADA 2022 criteria in between the age groups of 40 to 70 years. And the reason why I've taken 40 as my inclusion point is because the onset of sarcopenia starts at the age of 40. That is the reason why I have included from the age of 40. Exclusion criteria is all chronic illnesses like CKD, chronic heart failure, chronic respiratory illnesses, rheumatological disorders, malignancy, overt hypo or hyperthyroidism, Cushing syndrome, severe peripheral neuropathy, myopathies, and osteoarthritis of the knee. The last 3 because they'll not be able to complete the test for sarcopenia. At presentation, anyone who is in diabetic ketoacidosis, chronic drug intake like steroids, statins, or any other alternative medications, systemic infections like HIV and tuberculosis, substance addiction, and a BMI between less than 18 or more than 35, pregnancy, hypogonadism, and a HbA1c of 8.5, more than 8.5. So with the prevalence of sarcopenia at 8% in individuals with type 2 diabetes, to get a confidence level of 95%, the current study requires a minimum of 783 subjects. And yeah, so the statistical methods are that I'll be using a chi-square test as well as a student t-test for contiguous and non-contiguous parameters respectively, and logistic regression analysis will be done to find the independent factors associated with sarcopenia and sarcopenic obesity. The implications of the study is that recently data is emerging that individuals with just sarcopenia, just obesity, and as well as sarcopenic obesity, they differ in their complication rates, both micro as well as macrovascular on long-term follow-up. Though this data on, there is no data to compare that one group is better than the other. So I would like to see, initially see the prevalence as well as associated factors. And if possible, I would like to follow it up with a study wherein I could check their complications in the long term. And the advantage of knowing these associated factors is that we can as well target factors that are easily modifiable in preventing the development of sarcopenia as well as sarcopenic obesity. This is my budget estimate for the non-recurring consumables. I have summed up all the laboratory investigations, the kit costs, and I've analyzed it at 1,565 per subject. And for the DEXA scan, it is 1,500. And the rest I've calculated, and it has come to total budget of 29,59,000. I have a split of that independently. Thank you. These are my references. Thank you.
Nice topic, Dr. Harishita. How will you assess the exercise capacity of an individual?
So it's a questionnaire, sir. They have.
Any test will you perform for that?
We can use 6-minute walk test normally.
Will you like to review your slide? What have you written? And you spoke the same material, same words which have been written over there. No, next.
Yes, sir.
Next. Yes. What has been written?
Yes, sir. So these are tests for sarcopenia.
Physical performance of an individual will be assessed by
a 6-meter walk test. Sir.
6
meter. So
This
the
is 6
time
meter or
taken.
6 meter?
Yes, sir. These two are test specific for sarcopenia.
Okay, 6 meter walk test.
Yes, sir. Even 4-meter walk test is there.
There's a second cut of these many seconds.
Yes, sir.
So
It
sorry
depends
for
on
my
the age
ignorance.
again. Yes, sir.
The second thing I would like to mention that whenever we are saying that no similar study has been conducted in India, a suggestion, why can't we use the term from our country?
Yes,
Whenever we are saying from India, it seems that we are talking for somebody else. Yeah? So from our country, we can use it. Thank you.
There are 3 aspects to the definition of sarcopenia. What
Yes,
are
sir.
they?
So it is muscle mass, muscle strength, and physical performance.
Muscle mass, muscle strength.
Physical performance.
So muscle mass, how do you?
So we can do it either by DEXA or by bioimpedance electrical analysis. Both of them have been validated.
Right.
So what about calf circumference?
Yes, sir. They have developed cutoffs for calf circumference of 34 centimeters for
So
males.
you have mentioned it in your study.
Yes, sir.
But you have not put it in here.
I have mentioned it.
According to the
Elsewhere
current,
possible.
according to the current guidelines, is it possible to diagnose sarcopenia if you do not have access to DEXA or bioimpedance?
So calf circumference is an indirect community medicine
That's my
tool.
question. No, that I agree. We'll come to that.
Creatinine is a,
According to the current Asian guidelines, is it possible to diagnose sarcopenia
yes, sir.
if you do not have access to DEXA or to?
Yes, sir.
How
There is a
it?
SARC-F questionnaire. I'm not sure of the parameters, but
The current guidelines, the big issue is that this is to the best of my knowledge, but I'd be happy if I'm corrected. To the best of my knowledge, you can suspect, you can screen for sarcopenia if there is an issue with muscle strength, muscle function. But the diagnosis will be confirmed only if you show loss of muscle mass.
yes, sir.
And that is such a big issue. It means that if I do not have access to DEXA, I cannot diagnose sarcopenia, while I know that it is rampant in my community.
Okay.
So now actually newer Asian guidelines are coming, which are using a metabolic syndrome or a polycystic ovary kind of a diagnostic framework. So any 2 out of 3. So which means the criteria are the same, but now I have more freedom to diagnose.
Okay, sir.
Criteria to differentiate sarcopenia.
So there is no differentiation in the sarcopenia part, sir. It's just that their BMI is more, that's all. In the context of obesity, if they are still sarcopenic.
The criteria of sarcopenia plus obesity.
Yes, sir. Yes, yes.
So do you feel waist hip ratio or BMI, which would help find out sarcopenic obesity?
Waist hip ratio, sir.
So why BMI in your study?
Sir, if someone is healthy, I would
So
get
you
a
have
BMI
excluded
range.
people with extremes of BMI. Can't
Yes.
they have sarcopenic obesity?
Yes, sir, they can have.
So why have you excluded them?
I wanted one of the groups, I mean, my groups were all in the sense I didn't have an underweight group, sir. Malnutrition can be a significant risk factor for sarcopenia. So I didn't want to have an BMI of less than 18.
Would you like to slightly rephrase your secondary objective? Can you just go to your secondary objective once?
I'm not sure if I can use the word predictors, sir,
Study the predictors or find out the predictors?
to find out.
So you don't know the predictors.
Yes,
You're trying
yes.
to find. So in any research proposal, the objectives are very important. Wording is very important.
Yes, sir.
So that needs to be definitely known. Just one last question. You
Sir.
propose to do a bilirubin and calcium as well. They'll
Yes,
add to the cost. How will they help?
Calcium will just tell us, like, since I'm doing vitamin D, it might not add much value in the context of sarcopenia, sir, but I'm not sure. sir.
Okay. Nice.
Did you?
Doctor.
Test,
Yes, sir, that could also be a possible associated factor.
testosterone, did you add?
Yes, sir.
Yes, it was there. Dr. Harshita, so your idea is good, but how will you justify a budget of 30 lakhs for a cross-sectional study of 2 years duration, including 700 patients?
Yes, ma'am. Ideally, I would like to have it as a longitudinal follow-up study, but I actually wanted to divide them into these 4 groups and longitudinally follow them up till they have, and look for micro as well as macrovascular complications. But then I thought that might be a very big project that I can't write within 30 lakhs. So that's the reason why I thought, since this data is also not there, I wanted to, kind of do something on this.
What is the difference between prevalence and incidence?
So incidents are new cases, prevalence is the existing as well as the new cases.
How long will it take to assess prevalence of sarcopenia in any cohort?
It will not take a long time, sir. Cases are already existing there.
Dr.
So
Melinda is asking that. So cross-sectional
Okay, yes,
versus
sir.
longitudinal, that is the question being asked.
I don't know if it is newly developed or not, sir. So I can't say whether it is incidence or not, unless I've followed them up longitudinally for the development of sarcopenia, sir.
You want to do it in community level or in a hospital?
No, sir, I want to do it in a hospital setting.
That does
My
not-
hospital does not have a community type. That is
Okay,
one of
but
my.
that does not truly reflect the prevalence of sarcopenia. So
Yes,
that is
sir.
one of the drawbacks if you write actually prevalence of sarcopenia. And moreover, you have excluded patients who have diabetes for, let's say, 5 years, 10 years. So duration of diabetes does not have any relation with sarcopenia.
Sir, duration of from whatever data I have reviewed so far, duration of diabetes does not seem to have an effect on sarcopenia as previously thought. It is just the age of the individual as well as his HbA1c control.
Correct, but ruling out all those individuals who are diabetic for 10, 15 years, I think more people will be diagnosed with sarcopenia. if
So
you
the
take
reason
into
why I recruited newly diagnosed diabetics is because I thought, when I follow them up, there'll be more confounding factors. So that is the reason I thought I'll just do it at the point of newly diagnosed cases.
And patients who exercise more or athletes, they are less likely to have sarcopenia. So one of the means excluding factors would be those
Okay, sir.
that you have not taken.
Hospitalized patients means they'll come with so many other issues.
Can I ask one last question?
Yes, ma'am.
Why did you, what do you think is the reason why sarcopenia was less prevalent in Asian population? Any explanation?
You mean to say in that particular study or in general, ma'am?
In the study you quoted and also in general.
The European guidelines based upon their muscle mass, their criteria are set at a higher level. So by default, our muscle mass is slightly lesser. When we apply that criteria, the number of false positives are higher, ma'am. So we have to develop ethnicity specific cutoff. So when we apply our own cutoffs, it kind of became normal. Yes.
Good afternoon, dear judges and dear friends. I would like to take this opportunity to present my research grant proposal. And recently we had published a data from our center on the usefulness of adding on other parameters like hip structural analysis to a routine BMD in women who are admitted with hip fracture to know whether we could identify all the factors which are associated with the development of hip fracture apart from those which are captured by a routine bone mineral density. And after completing the study, the question which came into our mind was, what is the actual incidence of hip fracture in our community? Us being a tertiary care center, we deal with patients who are admitted with multiple places, but whether hip fracture is actually a concern in our community setup. So what is the incidence of hip fracture among postmenopausal women in southern India? What are the risk factors for hip fracture? After a person develops a fracture, it is a practice to start them on bisphosphonate therapy, calcium and 25-hydroxy-vitamin D supplementation. And can this intervention reduce hip fracture recurrence in a person who already had a fracture? And what is the mortality associated with hip fractures? So the title of my proposed study is Incidence of Fracture Hip in Indian Postmenopausal Women and the Effect of Calcium, Anti-Resorptive Therapy and 25-hydroxy-vitamin D supplementation on fracture recurrence and mortality. It's a longitudinal study and the acronym is called HIP-CADR-M study. The rationale for doing the study is that osteoporosis affects about 30 to 50% of postmenopausal women, and fragility fractures are considered to be an important complication related to osteoporosis. Hip fractures account for about 20% of all osteoporotic fractures, and they contribute to significant morbidity and mortality. Hip fractures are thought to be the most costly type of fracture for healthcare services, and there is risk of recurrent fractures. However, there is limited data which is available in our country. When we look at the 8 standardized hip fracture rates from across the world, we can see that women are more prone to have hip fractures compared to men. And this data is present throughout the world, irrespective of the continent where they were studied. But what about data from our country? Unfortunately, we don't have many data available regarding the prevalence of or incidence of hip fractures. And this was a study which was done in a hospital setup in Rohtak district in Haryana. And they looked at all women who were admitted with all people admitted with hip fracture in the year 2009. And the data was then used to extrapolate it to the whole community. So we assume that this being a hospital-based study, the true incidence of hip fracture cannot be identified in such a setup. And they also found that till the age of 55 years, the incidence of hip fracture is similar in both sexes, but after the age of 55 years, it is significantly higher in women. We are planning to do a longitudinal follow-up study over a period of 4 years after obtaining an ethical clearance from the Institutional Review Board. And we will be doing this in certain areas of Vellore district. And to just bring a little bit more clarity about where we are planning to do the study, the Vellore district has 20 blocks and we are planning to do the study in the blocks of Katpadi and Alangayam. This area covers a total population of about 1,20,800 and about 8,400 among them are above the age of 60 years. And women above the age of 60 years account for about 4,300. We will include all postmenopausal women above the age of 60 years who are belonging to this particular geographical areas. We would exclude those who were already having previous history of fragility fractures or on treatment for osteoporosis. If they have renal failure, CKD stages 4 and 5, those women who are not ambulant, or if they are already taking medications which can affect bone health. The reason for excluding women with previous fragility fracture is that initially it is only a follow-up study and we are not going to intervene or give them any supplement or medications to improve the bone health or prevent further recurrences. So hence, exposing people with fragility fractures who are assumed to have osteoporosis and not intervening would not be ethical. The primary outcome would be the incidence of hip fracture among these postmenopausal women. We also look at the recurrent fracture risk among those who have already fractured and has been started on anti-resorptive therapy, calcium and 25-hydroxyvitamin D, and also the 90-day mortality. We propose to include all women who with postmenopausal who are residing in this particular area for the purpose of our study. After excluding those women with previous fragility fractures, and also we will include those women who have not had a history of fracture. All women will be provided health education regarding the milk intake, regarding calcium intake, fall prevention measures, and they will be followed up whether they get any new hip fractures. And those women who develop a hip fracture within this time frame will be advised regarding the need for surgery, even though the budget of that won't be covered under our study. We will also make sure that the fracture prevention measures are emphasized. We study the bone mineral parameters. We will do the DEXA scan and also start them on calcium and 25-hydroxyvitamin D supplement. We will assess the age of these women and the age since menopause, the amount of sunlight exposure and calcium intake, their associated comorbidities, what is their vision assessment, and what is their risk fall, the fall for risk, the bone mineral parameters, including 25-hydroxyvitamin D, creatinine, and DEXA, because we found that the trabecular bone score and the proximal hip geometry is also helpful. We will include that in addition to the bone mineral density. And we will supplement them with calcium, vitamin D, and zoledronic acid for those women without any contraindication. So the main problem when we encountered this was that the follow-up period actually includes so much of manpower, and a significant proportion of the budget would be required for that. And in this 4 years, we may not be able to capture every fracture. So ideally, this has to be done on a longer term basis, but our immediate thing would be to cover for a period of 4 years. Thank you. Our target population in that, about the age of 60 years, is only for about 4,300 women.
How many do you expect in the 4 years that you will get?
Yeah, so the initial study which was done from that center, it was calculated based on the population census of that particular district, and it was about roughly 10 lakh population in that. And in that, the postmenopausal women in this particular age group was coming as about 15,000. And among that, they have calculated the fracture risk and said that it is about 129 per 1 lakh population. So they have extrapolated this data. So
130
per lakh per year.
Correct?
Yes.
So your one of the denominator is 4,000.
Yes.
For 4 years.
Yes.
Your follow-up.
Yes.
16,000.
Yes.
So how many fractures you are likely to get?
So for 1 lakh population, because we are capturing only about 129, for the 16,000, we are going to capture maybe around less than about 20 fractures, not more than that.
Because when you are given zoledronic acid for 100 patients,
The initial, our target was that if we are able to capture at least 100 fractures in this, but we don't have a true incidence of fractures in our community. And going back by the data which is available, very unlikely that we are going to capture these many fractures in our study. And after we go to the community and start our study, we may have to rephrase our objectives or increase the duration of follow-up which is required. And the budget allocation also may vary accordingly.
So any particular reason for choosing that community? Because as Dr. Harikumar was saying, only 8% were elderly in that community.
Yeah, the reason why we chose that particular community is that majority of bone related work has been done in that community, and we have some baseline data, ease of access, and we also know some baseline data about that community.
So you propose to use 4 milligram zoledronic acid, not 5 milligram, any particular reason?
By convention in our practice in CMC, we are giving only 4 milligram, and that is what is available with us. So that is only by our institutional policy that we are giving 4 milligram.
Any indication where 4 milligram is the preferred dose, not 5 milligram?
That I'm not.
Hypercalcemia of malignancy. How do you propose to measure sunlight exposure?
So sunlight exposure, it is only historically about
If you
the
ask
amount.
someone, how long are you out in the sun? It might be an arbitrary answer.
Yeah, the data what we are getting from this may still be arbitrary, but based on the previous data about
What
the
about clothing?
yeah, because all the data say that at least 12 to 18% of our body has to be exposed to 30 to 40 minutes of sunlight, and by the type of clothing which is worn by our women in those community, we hope that we can capture that amount of sunlight. And that is why the reason for including only ambulant postmenopausal women.
Studies which have measured sunlight exposure have traditionally taken the entire time spent outside, time spent between 10 to 3 and the clothing.
Yes.
And then you can make certain calculations. Just a couple of more questions. What, according to you, is the most serious complication of osteoporosis?
According to us, the most serious complication which comes to us is fractures.
Not mortality?
Mortality may be related to a fracture or directly.
For example, when you say the most serious complication of diabetes is myocardial infarction, not death.
Yes.
So you can put it either way. Just last question. Does calcium, vitamin D supplementation have a role in fracture prevention, osteoporotic fracture prevention?
One of the traditional risk factor for having a.
If you give calcium, vitamin D to a person at risk of having a fragility fracture, does it prevent a fragility fracture?
If they're having a low calcium and vitamin 25-hydroxyvitamin D already,
you're proposing to give it in the community. So does it prevent a fragility fracture?
So we are actually looking at in this whether giving that what is a risk of fracture in those, because traditionally in a person with hip fracture, the 4-year probability of them having another hip fracture is about 15%. So we are trying to see whether giving this intervention decreases that chance further.
Talking of review of literature.
Yes.
In the literature in a community, if you give calcium and vitamin D to all postmenopausal women, do you reduce the risk of fragility fractures?
That I'm not sure.
Dr. John.
Yes.
Dr. John, so I just one word of appreciation for your title, which included an acronym. So I think that was a good thing that you did.
That stood out from the rest.
Yes. One of the points I wanted to ask you is why did you limit it to 4 years? I'm presuming it's largely related to the budget.
Yeah, the main reason for restricting that was limited. Our constraint was the budget. We had to keep it to less than 30,000, and because it was 30 lakh, and because it was a small community, the amount of women whom we were having access to was less. So our idea would be to include the remaining or the surrounding localities also, so that in 1 year, the amount of women who are being studied can be more.
So in one of the slides, you showed assessment that will be done in women who do develop hip fracture, which
Yes.
included sunlight exposure, dietary recall, etc., etc. Are you doing those parameters in women who do not develop the hip fracture? as well?
Initially, when we are looking at the postmenopausal women and following up them for fractures, we are not looking at any of their baseline data. The reason being that if we identify factors, ethically it may not be correct not to address them. So as a general education, our social worker will be talking to them about the need for calcium intake, the sunlight exposure, but we are not assessing those parameters at baseline. It is only part of an education for everyone involved.
What is your second objective?
The second objective was in those women who already have a fracture, after supplementing calcium, 25-hydroxyvitamin D, and if they have osteoporosis, if we give them zoledronic acid, what is the risk of them having a subsequent fracture?
Then 4 years is probably.
Then again,
too
4 years
short.
is not adequate.
And are you looking at predictors for hip fracture?
The predictors of hip fracture in our study, we have only looked at the other functional limitations, including the visual compromise, whether they are having what is their propensity to fall and what is their calcium intake, and an indirect evident way of assessing their sunlight exposure.
So all of that you're doing only in people
Only
who are
after,
developing
only after they develop a fracture, our intervention starts from there. Till then, we are not.
It makes sense to do these assessments in women who do not develop fractures as well.
Yes.
Would you like to modify your?
Definitely, ma'am, because in a perfect situation, we should be doing all that to every women who are involved. But because it was only one social worker which we could include for this particular study, and we are covering all the 4,300. It may not have been practical. So if we have a extra budget allocation to recruit more number of people to study these women, then it would become definitely an option.
So good evening, one and all, respected judges, esteemed faculty members, and my dear colleagues. So the topic I have chosen for my dream research proposal presentation is pre-pregnancy lifestyle intervention to reduce recurrence of gestational diabetes mellitus, community-based cluster randomized control trial. I'm happy that two of my fellow participants have already dealt with gestational diabetes mellitus, but they have mainly focused on early detection and treatment of gestational diabetes. So what if we can prevent gestational diabetes from occurring? So I mainly chose this topic because of two reasons. One, I hail from the state of Kerala, which is often touted as the diabetes capital of the country, where the gestational diabetes is increasing at an alarming rate in parallel with the epidemic of type 2 diabetes. Secondly, if you are able to prevent one case of gestational diabetes mellitus, you are treating not only that mother, not only preventing the short-term and long-term morbidity of that individual, but you are influencing the morbidity as well as the future outcome of the offsprings that she's bearing also. So with this introduction, I have one specific reason also to take this topic, because I myself being born as a large for gestational age baby, and my mother was having GDM on insulin, and I had forceps delivery, I developed cephalhematoma, and 30 years down the lane, despite maintaining a BMI of around 23, still my HbA1c is in the pre-diabetic range. So statement of the problem, so data from India regarding the prevalence of gestational diabetes mellitus is highly heterogeneous, with the prevalence ranging from 6 to 25% based on various studies with higher prevalence in the South Indian states. And the previous history of gestational diabetes mellitus is in fact the strongest risk factor for development of gestational diabetes mellitus in subsequent pregnancies. So this is what I've mentioned, the impact of GDM on mother and child, both maternal and offspring short-term as well as long-term morbidities is there, including the future risk of obesity and metabolic syndrome in the child. So what is about the existing data regarding GDM prevention? So most of the literature have focused on institution of lifestyle prevention at the onset of pregnancy, but it has got some limitations because we have got only a narrow window of opportunity for lifestyle intervention. And also the mothers will not be able to follow the lifestyle precautions and the dietary precautions that they have been advised. But there have been data from the observational studies that weight loss that occurs prior to pregnancy has been found to reduce the incidence of gestational diabetes mellitus. So here comes the relevance of the study. So this would be the first randomized controlled trial to evaluate the effects of a lifestyle intervention delivered before pregnancy to prevent the recurrence of GDM. And if it is found to be effective, it could lay the groundwork for providing evidence-based preconception counseling to optimize the reproductive outcome of GDM and its associated health risks. So my primary objective is to compare the incidence of gestational diabetes mellitus recurrence among women with and without weight loss intervention. And my secondary objectives would to compare the parameters of maternal glycemia as well as markers of insulin resistance at the time of enrollment, at 16 weeks of enrollment, and at 26 weeks of gestation. And I would also like to compare the perinatal health outcomes of mother and neonates in intervention and control groups. So my study design would be a cluster randomized control trial, and it would be done in the field practice areas of the urban and rural community health centers in Thiruvananthapuram district of Kerala. So I would include those with a physician diagnosis of gestational diabetes mellitus. Usually the IRDPSD criteria is being used in Kerala widely, and they should be planning to have a baby in the next 1 to 3 years. They should have a BMI of more than 23, which is the cutoff for overweight according to Asia Pacific guidelines. And both breastfeeding as well as non-breastfeeding mothers are included, and they should have an access to the cell phone. So I would exclude those individuals who are aged less than 18 years, known case of diabetes, were harboring current pregnancy, or was using medications for weight loss or for infertility. And I would exclude also those who are not willing for regular follow-up. So based on the formula, the sample size calculation and estimating 60% recurrent rates on GDM, a number of 127 each in the intervention as well as control group is required to provide adequate statistical power of 90%. So this is how I propose to select my patients. There are a total of 21 community health centers and more than 1,000 Anganwadis in Trivandrum district. And out of that, by sequential random sampling, I would select 50 of them, 25 in rural and 25 in urban. And an Anganwadi would serve as the unit of randomization in my study. And women in 25 Anganwadis would receive intervention, and women in 25 Anganwadis will be the control. They will receive only health education, whereas the other will require weight loss intervention. So the ASHA worker would identify the from the ground level the eligible women, and they will be pre-screened via a phone call. And the research team comprising of a doctor trained in the dietary aspects as well as in the exercise aspect, as well as a trained dietitian and the healthcare personnel will visit the women in person, and after taking informed consent, history and relevant anthropometric measures and blood sample, and based on which Anganwadi they belong, whether they belong to the Anganwadi which is destined to receive lifestyle intervention or control, we would give them appropriately. So what are the interventions that we need proposing? So we would have a comprehensive health education incorporating dietary modifications, the exercise changes, and we would ensure ongoing contact and feedback from the participants. So what we aim is to achieve more than 10% weight loss in the first 4 months, that is 16 weeks after enrollment into the program, and we promote weight loss maintenance over the subsequent months. So how are we proposed to doing that? First is by dietary advices. We give customary dietary plans to each woman based on their height and weight. This is one of the examples that I provided. A printed pamphlet regarding what foods to eat and what not to eat will be provided. A dietary diary will be provided to them where they'll be recording all their meals and the meal timings along with calories. We'll be giving a list of them, and these data will be reviewed weekly and adequate feedback will be given to the women. Exercise advices is as per the protocol of the diabetes prevention program. You advocate for a physical activity of at least 150 minutes per week during the initial 16 weeks. And we would give each of them a pedometer, and we would like to make the goal reach 10,000 steps per day. So follow up after the initial visit, there will be a weekly follow up by the trained staff in person or by the phone or via video conferencing every week. And we will also conduct monthly group discussions and group sessions for participants Anganwadi wise. So my primary outcome is to identify what proportion of these women develop GDM in their next pregnancy. So that would be done as per the standard criteria. Between 24 and 8 weeks of gestation, we would do an OGTT, and based on the IADPST criteria, we make a diagnosis of gestational diabetes mellitus. So secondary outcomes, we would look at the maternal anthropometric measures at the baseline. We look at the height, weight, BMI, as well as waist-hip ratio. And during pregnancy also, we will look at the amount of weight gain that has been obtained by the mother, and also look at the maternal insulin resistance parameters by HOMA-IR and leptin and adiponectin levels, and also look at the maternal and neonatal consequences of gestational diabetes mellitus. This would be the biochemical test I would purporting to perform. So, and these will be the maternal consequences, the immediate consequences, the preeclampsia, the presence of polyhydramnios, preterm labor, the need for CS delivery, traumatic labor, and also the immediate offspring consequences will also be looked at. So this is in summary of what all things will be looked at the pre-pregnancy. We will do at baseline at 4 months of intervention, and till the pregnancy is achieved, we follow it up for every 4 months. And then we will look at 24 to 28 weeks and also at postpartum period. So the relevant statistical methods will be done, and we will mainly calculating the relative risk of GDM recurrence in the intervention and control group. And we also do a multiple logistic regression analysis to examine the effect of treatment group on the proportion of women who develop GDM. So ethical considerations, the study would be started only after approval from the Institutional Ethics Committee, and we would always register the clinical trial registry of India. And whatever result which has been found to be abnormal in the investigations, we would make sure that adequate treatment will be given. This is the proposed timeline. Once the adequate finances are allocated, we would be able to complete the study in 4 years and thereby submit the report. This is the proposed budget also, which would come by around 30 lakhs. So I've excluded the salaries of the project staff because we already have the staffs in a department. Otherwise, the budget would exceed. So I've excluded them from the budget, and this would come around 30 lakhs. Thank you. I once again reiterate the fact that if we are finding this an effective intervention for prevention of GDM, that would be a breakthrough achievement, because these women who had a history of GDM will be highly motivated, and thereby you can make them do these things to achieve the target lifestyle goals. And thus, by preventing one case of GDM, you can prevent the morbidities in mother as well as the offspring. Thank you.
Dr. Karthik, nice presentation. In your review of weight loss studies, how many studies might have achieved a target of 10% weight loss?
They have not set it. None of the studies have set a specified weight loss target, sir. They have given the interventions.
What I am asking, that out of 100 studies on weight loss, how many have achieved 10% weight loss?
So that will be less than 1/4, sir.
So it's very less. So over a period of years, you must have observed that initially we used to aim at 10% weight loss to prevent diabetes. Gradually it came down to 7%, then now even 5% will do sufficiently well. So reducing 10% weight is a tremendous job and difficult to achieve. So one thing is we are probably planning a study to fail.
Sir,
we will not achieve its objective.
Sir, I was hoping
just
that
taking Dr. Agarwal's word forward, in other words, if you get 10% weight loss in your intervention group, is there any chance that you're actually going to fail in your study? Which means that if there's 10% weight loss, is there any chance that the group which loses more than 10% weight has similar or more GDM compared to the group which does not? Is there any chance in this study for such a reverse outcome? You're trying to look at something.
Will you end up with a paradox?
Paradox, exactly. Isn't it obvious that you'll get a better result?
So we hope so that sometimes the excess weight loss can again.
So I think rather the emphasis would be more on how you aim to achieve that weight loss.
Okay, sir.
Different types of intervention to achieve weight loss, which is better. I think
Okay,
that would be something more practical.
Which are the, and I want to see the diet slide again.
Yes, sir. With the history of GDM, sir.
He said he'll do a weekly review and they will get back, but it's difficult.
What is the difference between primordial prevention and primary prevention?
Primordial prevention is you prevent the emergence of risk factors, whereas the primary risk factors are present, but you prevent the onset of disease.
Can we come to that slide on diet?
Your diet slide, please.
Just find 5 errors of omission and 5 errors of commission in this. Shabash. Let's try.
So this is not a standard thing, sir.
5 errors of commission and 5 errors of omission in this slide.
So at least a couple, if not 5.
The carbohydrate, the proportion of the.
What you do is you start from the top and then you go to the bottom and you just keep on listing, sir, this is an error of commission, this is an error of omission. Let us see how many we count. Let's start from B.
Sir, the amount of calories advised.
Who's your best friend? Who's your best friend?
Dr. Lavanya.
Actually, errors of commission. This is really important. We should spend 2 minutes on this, because if you think that doing DM endocrinology is just about learning about irisin and learning about vitamin A, then you are missing the wood for the trees. It is about diet. And if you think that there will be dietitians at home later on in practice to help you, that is also wishful thinking. Do you know how to cook? It is my personal belief that you cannot be a good endocrinologist if you cannot cook. So cooking की तो अभी हम बात ही नहीं कर रहे. We are not speaking about cooking at all. But Lavani tried to help him out. Errors of omission and commission. And again, we will not move ahead until all of you put together count those 10 errors in this slide. And you can also focus. I mean, while she's trying to help you, you can help yourself. Okay, that's one. What else?
Will be can't provide a printed pamphlet for diet because diet will vary from each household to household and depending on cultural preferences.
That's two.
So you cannot give
Okay,
a
two. Yes.
standard diet to entire
Right.
population, expect
Two.
them to follow it.
Okay.
Then,
Any error in English?
So the use of ladies.
But now you're finding it. Okay, what's the plural of advice?
So, okay, sir, it's advice only.
Yeah.
Sir. Is
And
advice
then
only,
who
sir.
told you 50, 25, 25? Does it have to be rigid? Like, do you wake
No,
up at
sir.
6 a.m. every morning and then do you wake up at...
No, sir, I've told you'll be customizing the diet, sir. We'll be talking with them. What
You
all?
have not written that.
Yes, sir. But
And if I'm a lady who is 170 centimeter, I will also get 1200. And if I'm 151 centimeter, I will get 1200 calorie diet. If my weight is, if my BMI is 23, I will get 1200. If my BMI is 29, I will get 1200.
No, it's not like that, sir. So will be based.
This is a big issue. It is, why are you not able to find this, all of you? Tell me 5 good things in this diet. In this slide.
So one thing we're specifically mentioning about what all things to be avoided. So
What is definition of junk food?
So I meant I will be giving a list of foods, sir, that
This is your whole study is dependent upon this young man. This is the pillar. It is the only pillar of your, and along with exercise, this is what your study is depending on. And with this, you want a moonshot. You want 10% weight loss. Is plantain junk food or good food?
Sir?
Plantains, bananas.
It's a good food, sir, but it can.
And if I drink, now we are not supposed to take brand names, but I know of a beverage known as Enerzel Zero. That is an electrolyte drink that has got 0 calories, but that is colored. It is, I think it is orange in color. So why can I not drink that orange colored beverage? How many calories are there in kokum juice? Kokum, it comes from Konkan area. From Goa, yeah. Answer is 0, but that is colored. I would very strongly suggest all of you to read about nutrition before you come into practice. And please read in a very humble manner. Read about nutrition, read about diet, read about culinary science. Whenever you are in a hotel, take the opportunity to meet with the chef. How did you cook this? How did you prepare that? How did you plate that? How did you preserve it? The better you are at cooking, the better endocrinologist you will be. You will be able to justify properly.
Very less carb.
He has given so many negative things and there is not a single positive thing. What should I eat? Supposing I am a 160 centimeter lady with a BMI of 30, then what should I eat?
So it would be based on the ideal weight, sir.
Who will tell me that? Where is it in your methodology? If it is not written, it means you have not thought of it.
No, sir.
Your topic is lifestyle. So you should be an expert in lifestyle. And please take this as a wake-up call, not only for you, but for everybody. It is easy to pass the DM exam. but it is not easy to learn this. And again, I would just repeat, learn about nutrition, diet, and culinary science, and learn in a very humble manner. Be humble when you are learning. So by tomorrow, you will give me that list of 10 errors. In it, na?
Cooking fat, cooking oil is probably a bigger culprit than the energy ingredient of a particular. So we use a lot of oil in north, in south, in east, west, everywhere. So the nutrition value altogether changes after cooking. So cooking oil is very important. It needs to be remembered.
So the chemical formula, it contains a lot of lauric and myristic acids.
One more easy question for you. Define what is alpha error. Alpha error.
Alpha error means the hypothesis, before the study, you propose a hypothesis that there is no difference between the two groups. So alpha error is that the hypothesis is actually correct and you are wrongly rejecting. Oh, sorry, it's otherwise. The hypothesis is wrong, but you are accepting it by mistake. Sorry.
Okay, I think your idea was good, like Dr. Sanjay Kalra pointed out, and Dr. Pankaj Agarwal also pointed out. I think your intervention has to be very, very specific. If not, you're bound to fail in your study. I mean, that is for all of you, not just you. Even in future, when you plan a research project, your intervention has to be very clear in your head. If not, you're bound to fail, like he mentioned. So,
It's all about methodology.
Yes.
Just show your title and where I changes what your title. Lifestyle intervention to reduce recurrence of GDM. Do you advise everybody to lifestyle after if they have had GDM?
Yes, sir, but there is no recommendation as to what should be the ideal. We all advise, but whether they...
Your advice is what is the control group? Control also you are advising lifestyle.
Yes, sir, the routine standard of care, sir. Probably.
So you're not specified, you're aiming for weight loss. If you're not specified at all, I would advise anybody who had GDM, I would advise lifestyle. That's the standard of care.
Okay.
So what are you randomizing it?
Would be a weight loss intervention.
So your one arm is not at all reflected in your heading itself.
Okay.
Just last question, and we'll answer this later on, maybe tomorrow. What is intensive behavioral therapy, IBT, and what is the relationship with obesity and weight loss? But that you answer later.
Just one more. Would you like to exclude breastfeeding women or include them in your study? You are planning for 10% weight loss.
Breastfeeding can...
You said you would include them.
Yes, I would include, sir.
Just one question, duration of intervention, does it have any role? Let's say one conceives after 3 years of following lifestyle intervention, one conceives after 1 year. So
but the problem is that they won't be able to, may not be able to maintain whatever gains they have achieved on the initial intensive phase. So as early as the maximum intervention is made and the weight loss is achieved, as early if they get pregnant, then the benefit would also be maximum. Or else if they are able to maintain the gains or the weight loss.
no, I'm asking the other way. Means suppose a woman continues the intensive trial for almost 3 years, the chances of getting GDM will be definitely less in comparison to who stops it after let's say 1 year.
Would still be better than the control group, but may not be as good as the one who gets pregnant earlier. Thank you.
Good evening, respected judges and dear colleagues. Today, I would like to propose a study for the research and application to Endocrine Society of India for the study of effect of the prior testosterone therapy on fertility induction outcomes in a patient with a hypogonadotropic hypogonadism, a prospective observational study. So we know hypo can be congenital or acquired, and broadly we have two treatment options. One is the testosterone replacement therapy, which can induce virilization but not the fertility, and another is the gonadotropin treatment, which can induce fertility, but it is cumbersome and costly treatment. So my research question is, does the prior testosterone replacement therapy affect the fertility outcomes in a patient with a hypo when treated with the combined gonadotropin therapy? So coming to the review of literature, the first one is the Restali et al. It is a meta-analysis including 30 studies. And the conclusion was that the previous TRT, that is testosterone replacement therapy, does not affect the sperm concentration achieved. And also they found one important finding that various FSH preparations have similar outcome. So either it is recombinant or a urinary derived, they will have a same outcome. Now another study, which was retrospective, including 75 male, they found that prior TRT resulted in a delay in achieving the peak sperm concentration and lower likelihood of the conception. The only prospective study in this area which I could find was by Royam et al. Published in JCEM. They included 60 patients. In the group A, there were treatment naive patient, and group B, the patient who received the prior TRT. And they could find that mean sperm count was not significantly different between two groups. The another large cohort study again found that prior TRT does not affect the sperm concentration achieved. Recently, in 2021, published study, one study published from the KEM, they included 35 patients, and they could find that patient who had received the prior TRT achieved significantly lesser sperm concentration. And that outcome was mainly driven by the severe phenotypic patient. So overall, there is no consensus in this area, as we have seen that the results from the different studies are very conflicting. One study says that it does affect, another study says that it does not affect. That is because there are lack of significant number of prospective studies with a good number of the sample size. So my study methodology would be prospective observational study, which will include 14 to 23-year-old male with a diagnosis of hypo, which will be diagnosed by standard diagnostic criteria. The duration will be 24 months, excluding the enrollment period. Exclusion criteria will be functional, hypo, CDGP, acquired hypo, and reversible hypo. My primary endpoint for this study would be mean difference in the peak sperm concentration achieved between two groups, and the number of patients achieved the sperm count of more than 10 million per ml in two groups. The secondary endpoint will be bilateral testicular volume achieved, qualitative semen analysis, time to achieve the peak sperm concentration, inhibin B level, and the subgroup analysis of severe and partial phenotype, that is testicular volume less than 3 and more than 3 ml. So we will divide our study cohort into two groups. Group A will be treatment naive patient with hypo, that is newly diagnosed patient with the congenital hypogonadotropic hypogonadism, and group B will be already diagnosed patient and patient who have received the testosterone previously. So they will be like somewhat virilized patient. But if treatment is given for 3 months, like for the priming by suspecting CDGP, it will be not considered as a prior TRT. The treatment protocol for group A will start with the HMG 75 unit thrice a week and increase it up to 150 unit thrice a week subcutaneously in case of inadequate inhibin B response, that is less than 80 picogram per ml. Along with that, we will start with HCG, beginning from 500 unit twice a week, and titrating it up to maximum of 2000 units thrice a week to achieve the peak testosterone level of more than 3.5 nanogram per ml at the end of 1 year. The group B HMG will be given in the same manner, but we can start with a higher HCG dose directly because they have already received the testosterone previously. The treatment completion will be considered once the plateauing of the sperm count occurs in both the group. The follow-up measurement will be clinical assessment and the testicular volume, tender staging, any extra reproductive feature which can suggest a syndromic diagnosis of hypo, presence or absence of the cryptorchidism, and duration of the testosterone therapy in the group B patient. Biochemical assessment will be FSH, LH, and testosterone at baseline, and then testo at 3 monthly on follow-up. Inhibin B at baseline, 3 months, 12 month, and final assessment, and semen analysis every 3 months after completion of 1 year of treatment until the plateauing. So I have chosen the sample size formula for the proportion. In KEM study, I could find that more than 10 million sperm count was found in 53% of the patient of the group A and 12.5% patient in the group B. So on basis of that, we require at least 30 patients in each arm. Total number of patients will be 60 required for this study for the defined primary outcome. The primary outcome will be compared with the standard t-test if the data is parametric, and otherwise Mann-Whitney test if data is non-parametric. And the contingency categorical data will be compared by the chi-square test. So coming to the budget, so we don't have inhibin B as now in our department. So that for the kit will need to be purchased. It will cost around 90,000. Each and every patient will undergo inhibin B by this. But cost of injection is a little bit higher side. This is a minimum injection code price I could find from the pharma company providing the injections. Still, it is a total injection cost for HMG will be 66,96,000. So that will cost around 1,11,600 for the per patient over the 2 years. And same way, HCG injection will cost around 46,800 per patient over the 2 years. So if I can propose the grant for 30 lakh rupees, we can sponsor 18 patient treatment out of this. Rest of the patient can be included with other schemes like railway CGHS, or the self-paying patient will also be included in the study. So till now there is no major prospective studies in this area. So this study can help clinician and making the treatment decision more confidently. If we can find that there is no difference in the sperm count achieved, then we can easily start patient on testosterone directly without any confusion. And then we can follow up when fertility is required. This is my study performance. Thank you.
What is the total duration of duration of study you have planned?
So 2 years, excluding the enrollment period.
Okay, and what is the usual duration of puberty in a normal male child?
It's around over 3 to 4 years.
So do you expect that within 2 years of treatment, one will become fertile?
Sir, the physiological puberty is really it's very slow, but whatever I have found from the previous study, 95% of the patient achieve the peak sperm concentration within 2 years of the treatment.
You will begin with HCG and add HMG later, or you will begin with both therapies together?
Sir, here I have kept both together because recent study from the PGI has found that there is any advantage of giving FSH first followed by HCG.
Even with
only increase the
testicular
treatment
volume
duration.
of less than 3 ml, you will begin with both
Yes, sir.
therapies?
Yes, sir. Because their argument was that HCG will take some time to increase the intertesticular testosterone. It will take 6 to 8 weeks. So by that time, FSH will act and we can continue therapy together. Even
2000 unit of HCG will be.
no, sir. We will start with 500 unit of HCG in the treatment new patients.
But 2000 unit as a final dose will be there, and the maximum dose?
2000 unit thrice a week, maximum dose. But we
Is
will
it
start
adequate?
with 500 unit.
You find it adequate? 2000?
Yes, thrice a week, 2000 unit is. Yes.
What is the maximum dose of HCG that can be used in such patients?
Sir, they have tried even 5,000 unit thrice a week also have been tried in previous studies, but most studies have found a good result with 2,000 unit thrice a week.
But why did you sort of apply this break of 2000? And then in one sentence you say 2000 thrice a week to achieve testosterone level of such and such by 1 year. Supposing the testosterone level is not achieved, then what do we do? So what do we do if the testosterone level is not achieved?
Yes. So
what do you think the minimum testicular volume should be to achieve success in terms of spermatogenesis?
12 ml, 10 to
12?
The minimum.
Which hypogonadotropic hypogonad would have a
Well,
testicular volume of 12 ml?
No, sir. But after the end of treatment.
The baseline, how much? Baseline, how much is required? Baseline, how much is required to predict success?
More than 3 ml, sir.
How do you measure testicular volume?
Sir, in this study, we are measuring with orchidometer, which is very subjective. Ideally, we should do with the USG, but it will.
So you are willing to do inhibin,
Sir,
ideally, but you don't want to do an ultrasound. It's not available in Hyderabad.
No, no, sir.
Maybe, I mean, you never know.
Yes.
In which year did Prader invent the orchidometer?
I'm not aware, sir. for that.
Which orchidometer do you have? Do you use it in practice?
Yes, sir. Prada, sir.
Such mein? When did you procure it and where did you procure it from? Chal, karke aa gaya. Haan. Where did you procure your orchidometer from?
Sir, it is there in
Work in progress. Huh?
No. It is there in department, sir. We have not
That is
procured.
locked, that is locked in the HOD's cupboard. You are doing a thesis on gonads. You have gone out of the way to choose Prader's orchidometer. You have not mentioned ultrasound. You do not have an orchidometer of your own. You are willing to do HMG, you are willing to ask for 30 lakhs budget. What should the person who is going to give the budget, what should he think about this project? No, you answer, what should we think? You want 30 lakhs and you don't have an orchidometer, you are not willing to do ultrasound.
No, sir. We have, but I have not procured by myself.
What is the color of orchidometer, of Prader's orchidometer? What color is it?
So that we have two variants. One is that maroon and green and yellow, and all yellow.
And what is it made of? What material?
Wooden.
Pass that is one thing. Correct.
What is your
No,
study title? Can you just come
How
to
many of you have your own orchidometer? Where did you procure it from? How much did it cost? So why could that not have entered?
If you are members of the endocrine society, you can also buy it from there. They ship it to India.
Yeah.
So
You have? What color is it?
So
IKEA would.
So you plan to look at fertility outcomes. And
Fertility induction
outcomes, and you are measuring peak sperm count.
sperm concentration.
So are they similar?
No, sir. We are not looking at the pregnancy
So
rate.
would you like to rephrase your title? The title of a study is very important, the most important thing in the study.
We can look at the effect of the testosterone therapy on peak sperm concentration outcomes in patient with
more accurate.
Right.
One question from me. What is the difference between an observational study and an interventional study?
So in intervention, we are specifically intervening. We are keeping some difference between two groups of the study. We are specifically providing one extra thing to another group in intervention study. Here we are providing treatment to both the groups, group A and
So,
group
but that's
B.
not intervention?
So are you observing alone, or are you doing
But there is no
something?
difference of the intervention between two groups.
What is an observational study? Can you define an observational study?
Over the period of some time, we are observing the outcome.
So do you think this is observational study or interventional study?
What you have proposed, is it an observational study or an intervention study?
We give you a chance to rephrase the entire title once more. Would you like to rephrase it?
Still, well, sir, I am not convinced with the intervention because this is also the standard of care treatment also is same as of now. Yes, sir. So one group has a history of the prior testosterone therapy. That is the only difference. But now we are starting the similar treatment in both the groups.
So in an observational study, you don't do anything. You just watch the patient from outside. You're not going to give any intervention, whether it's to one group or two groups, it doesn't matter. Here you are giving an active drug. So this is no longer an observational study. It's not a randomized control study, agreed,
Yes.
but you're having an intervention. So it's no longer an observational study.
Okay. Thank you.
Good afternoon, respected judges and my dear friends. First of all, I would like to thank the Endocrine Society of India for having me here and giving me an opportunity to present a research grant application. I come from an institute which is known for its expertise in bone health. And hence, my dream project does have some link to bone health. But first of all, I would start by paying respect to the Padma Shri awardee, Srimati Manjamma Jogatti, who has received her Padma Shri for her contribution to folk dance from Karnataka. And this is a socially oppressed class in our country. And as endocrinologists and as the thinking contributors to the society, it becomes our duty to at least physically transition them from their gender to their desired gender in a really safe manner. So that would be our main objective. And hence the title of my study is to understand the bone and metabolic health in trans women after 1 year of gender affirming hormone therapy. Now, if you look at the prevalence of transgender population in India, the data are limited. From the India's 2011 census, we have about 4.8 million Indians who are identified as transgender, and the highest proportion in Uttar Pradesh of 28% and in Tamil Nadu of more than 4%. But we know that this is grossly underreported, and there is a much higher prevalence of the transgender population in the country. So, though they are a socially oppressed class and they do not come out too much into the public, they are forced to approach us endocrinologists. Why? Because gender affirming hormone therapy is very much important to them. It aims to align the characteristics of the individual with their gender identity, and it is a safe and effective hormone regime that they propose. So there are two objectives to this. One is to suppress the endogenous hormones, sex hormone secretion, which is determined by the person's genetic or gonadal sex. And secondly, they want to maintain the sex hormones levels according to the person's affirmed gender. So there are two objectives why they approach us. So the need for this study is that because this therapy is integral to the management of these, and the studies on the effect of such hormones on cardiovascular and bone health is limited. There is a lack or absence of large cohort studies. There is a lack of appropriate control population and inadequate data acquisition from gender identity services. And even lately, we are poorly trained to give training on the care of these transgender patients. So according to the Endocrine Society guidelines on transgender population, they only recommend a BMD measurement when risk factors for osteoporosis exist, especially on those who stop the sex hormone therapy after a sex affirming surgery like a gonadectomy. So this is the Endocrine Society guideline for a DEXA scan. And what are the treatment regimes which they propose for trans women? So what I would be focusing is on the trans women, that is they are born male at birth, but they want to transition into a lady. So the three hormone regimes which are recommended are three, that is the estrogenic preparations, anti-androgens, and the GnRH agonists. The GnRH agonists we would not deal with because they are mainly given during the pubertal period to suppress the sex hormones, not in an adult population. The others are the estrogen and the anti-androgens. So in a new study, that is there is very paucity of Indian data on these aspects. So one of the recent study which appeared in the endocrine journal, European Journal of Endocrinology, is about the body composition, bone turnover, and bone mass in trans men after testosterone treatment for about 1 year. And they assessed a number of parameters, and the body composition also was assessed in control women and trans men before and after 1 year of testosterone therapy. And they found that this actually induced some changes in body composition, including a gain in lean body mass, muscle mass, and strength. And there was an increase in the bone turnover markers after the first year of testosterone treatment. So what about the bone health in trans women? There is a high prevalence. It is shown that there is a high prevalence of low bone mass when compared to reference men, both even prior to the gender affirming hormone therapy initiation and while on this gender affirming hormone therapy. Study, because there are very far and few studies of this population. They have shown alterations in BMD measurements prior even to the hormonal treatment, and they have hypothesized that it could be independent. They are at an increased risk of osteoporosis because of reduced levels of physical activity, low muscle mass, grip strength, and they have low levels of vitamin D. And this is a forest plot which shows a recent meta-analysis done in a similar study before and after this gender affirming hormone therapy. Though they did not find a definite increase in BMD, they found the conclusion of this study was that the research with trans women and longer follow-ups with a standardized estrogen therapy and larger samples is needed to obtain more robust evidence on the impact of cross-sex hormone therapy on bone mass in the long term. So, and even if you look at the cardiometabolic health in trans women, the risk of death from cardiovascular disease is said to be threefold higher than from all the other groups. And in the meta-analysis of 29 studies, they found that those who were on oral estrogen, they were found to have significantly increased triglycerides at the end of 2 years of study. So the primary objectives of my study are to assess the bone health with bone turnover markers, bone mineral density, trabecular bone score before and after 1 year of gender affirming hormone therapy in transgender women. And my secondary objectives would be to also assess the cardiometabolic parameters and the quality of life before and after 1 year of this treatment. So the study design would be a non-randomized controlled study design or a quasi-experimental study, because we are having two groups here, those who are the trans women and the normal men. And we are going to intervene in the trans women and we are seeing the outcomes. So it is a we are not randomizing them. So it is not a randomized control trial. It is a quasi-experimental study, and my study subjects will be the transgender adult women who will be attending the transgender clinic of a tertiary care center in South India. I have not decided the exact clinic or hospital because there are multiple transgender clinics which are coming up around the country, and I would propose a collaboration between all the clinics for this study. With the study period, I have put it as 1 year, but of course, when we identify a cohort of such a group, we can always follow them up. So the eligibility criteria for this study would be, of course, the Endocrine Society guidelines, which say that the gender dysphoria, they should have certain criteria before we start this therapy. They should be referred from a proper mental health professional. They should have a gender dysphoria of at least 6 months of duration. There should be a marked incongruence between, so this will be assessed by the mental health professional and they would be referred to us. And what is the indication for starting the therapy? If you have a well-documented gender dysphoria, the person has capacity for a fully informed decision and consented for treatment, the age of majority in a given country, which is 18 years, and mental health concerns should be reasonably well controlled. So the inclusion
Sorry,
criteria.
Dr. Krishna, you have taken more than 2 minutes.
Yes,
in
yes,
extra,
sir. Yes.
in
So
excess.
this would be the assessment, sir. This would be my study algorithm where we have 2 sets and then we go through a detailed demographic history, the biochemistry, the DEXA parameters, and we are looking at oral estradiol therapy. And after 1 year, we would be assessing these parameters again. The sample size calculation would be from, I would base it on the previous study of 23 individuals doing a paired t-test. And this would be, and from this, I would be getting a study subject population of 40. This would be my bone health proforma. This would be my biochemistry, the DEXA parameters, the questionnaire which I would give them. This is the modified short form 36 questionnaire. And this would be my budget data, which I propose with at least 21 lakhs, as 21 lakhs or 22 lakhs to be precise. and depending upon whether I increase my subject size also. So the impact would be that it will be the first study from India on trans women and bone health, and we are identifying a cohort for further studies in future, and we are going to become more wise with regard to the accurate dosing, the routine monitoring, or the thrombotic complication risk in these transgender population. Thank you.
So you have eaten our time. So number one, how much impact on bone health, bone parameters do you think will appear in 1 year of time?
So it would be less, but I was hinting at a normative data for these individuals. Usually it takes much more time, and estrogen generally will there have been studies in trans women. It causes an increase in the lumbar spine density after 1 year of hormonal treatment. That is
So
one
it
of the
should be
results.
above
It
at least
increases.
the coefficient of variation
Yeah.
which would occur in 1 year period of time.
Yes,
At
sir.
least, so-
It increases the lumbar spine BMD is what it shows.
Why were patients not taking spironolactone in the study, or why were they excluded?
So spironolactone itself can increase the BMD because of the anti-mineralocorticoid effect, and decrease in calcium and increase in calcium absorption can reduce the PTH. So I would like to have a definitive treatment so we can measure the parameters before and after rather than a number of medications.
Estrogen also would affect bone density to some extent.
Yes, sir.
So you have included estrogen but not spironolactone in your study. Spironolactone is often used in gender reaffirmation therapy.
Yes, sir. Yes, sir. But
So any specific reason for excluding
usually, so when we start the gender affirmation therapy, there is a proposal to start on estrogen and later on add the anti-androgens. So because I'm taking a treatment naive patient and following for 1 year, I was thinking of.
Don't you think adding spironolactone would further lead to more accrual of peak bone mass, or let's say increase in the bone mass,
Yes, sir. Yes.
rather
it-
than depriving them of spironolactone?
Yes, sir. We should not deprive them of that, and it should be added on at the later stages after the after we reach, like we are going to check for the estrogen level and testosterone, monitoring them at regular intervals. And the Endocrine Society recommends an estrogen level of 100 to 200 picogram per ml and a testosterone less than 55 nanogram per dl during these follow-up visits. So if we are not achieving these targets, we should add on the anti-androgens also.
Any of your patient in the cohort, they have undergone SRS or gonadectomy?
No, sir, that I am excluding. So that would change the results of the study. Only treatment naive, sir.
How do you monitor someone on estrogen or as a part of gender reaffirmation therapy?
So we have to monitor the estrogen levels at 3, 6, and 12 months in the initial year of therapy. And then once as I said, the cutoff levels have been achieved, after every 6 months is almost.
This is the efficacy part. What about the safety part?
Safety part, the cardiometabolic profile, that is, we have to check for the lipids, the HbA1c, the prolactin levels have to be monitored. Sir.
Anything about liver function?
Yes, sir, liver function also. Sir. Yes.
So do you think we should mark you for the question answer session as well?
Thank you.
Good evening, respected faculty and my dear friends. My title for today is Telemedicine for Secondary Prevention of Diabetic Foot Ulcer, TelePod, that is POD for podiatry, a randomized control trial. Coming to the background and need for study, the lifetime prevalence of foot ulcers in patients with diabetes mellitus is 19 to 34%. So almost 1/3 of them get foot ulcers. Once healed, the risk of recurrence is very high, up to 40% the first year and 60% within the next 3 years. A patient education regarding foot care has time and again been shown to reduce reulceration. Example studies by Malone et al., Monami et al., and it has also been shown to reduce amputation rates. However, some other studies have shown that there is lack of benefit even after giving education. So what may be the reason for the lack of benefits in other studies? Probably because these studies focused only on one education session and did not follow it up. So there was lack of reinforcement and probably the patient's inability to come for frequent follow-up. In this era, smartphones are ubiquitous and teleconsultation by video calls to reinforce learning and facilitate behavioral change may be a viable option in resource-poor settings. So this is my hypothesis. Among type 2 diabetes patients with a previous history of foot ulcer, that is the patient population, patient education by telemedicine, that is the intervention, increases the time to development of new foot ulcers, that is the outcome, compared to standard outpatient care, that is the control population, at 1 year follow-up, that is a time interval. The objective of my study is to assess whether telemedical education, that is on top of standard care, increases the time to re-ulceration in diabetic patients as compared to standard care. So the study design will be a 2-armed parallel group, open labeled prospective RCT with a blinded endpoint analysis, that is a probe design. It will be done at St. John's Medical College, Bangalore. I'll be selecting a study duration of around 1.5 years from June to December the next year. And ethics committee approval from IEC will be obtained and also the CTRI registration. Coming to my study population, I will choose patients with type 2 diabetes attending the endocrinology or general surgery OPD in our hospital who had a history of healed foot ulcer, that is within the last 2 years, or a history of amputation, but they should be ulcer free for at least 28 days and they should be giving informed consent. I will be excluding patients who have critical limb ischemia or nearing critical limb ischemia, who have cognitive, visual or hearing impairment and cannot communicate well over the telehealth, and those who do not own a smartphone. So this will show my study protocol in brief. After baseline history, examination and routine lab investigations, all the participants will be treated according to standard guidelines and receive education regarding footwear, that is all the population, both the arms. They will then be randomized, that is 1:1 randomization by a computer-generated random allocation sequence into 2 arms, the control arm who will receive standard outpatient care and the intervention arm who will receive telemedical education in addition to standard outpatient care. So more about my control and intervention arms. Control arm will receive standard care and education. They will be advised 3 monthly outpatient visits as is practice. And in case they do not turn up for follow-up, they will be telephonically contacted at 6 and 12 months to inquire about the clinical status if OPD visits are not done. The intervention arm, in addition to standard care and education and after advising 3 monthly visits, they will also get a video consultation from a trained nurse every week who will explain regarding the foot care, who will inquire whether the patient is complying with the instructions, who will advise the patient to examine the foot while on the call, and who will virtually examine the foot. In case if the video is not available, they can at least have a telephonic conversation. And in case if the patient is in rural area and there is no network and patient is not contacted, at least they will be advised to keep a checklist, keep a calendar, and someone in the family will be advised to take a photo and send to the healthcare worker every week. The clinical care of patients in both the groups will otherwise be unaffected. In case they develop any complication, they will be treated equally. So this shows a brief, the patient education module, a brief explanation regarding the principal cause of foot ulcers like ischemia, neuropathy, and then examination of the feet and any personal risk factors like any deformities, ischemia and neuropathy will be identified, and it will be explained how to, what to do about it. Examination of shoes and insoles to look for any faulty footwear, and can also advise to adopt preventive behaviors like washing, drying, moisturizing the foot, self-examination of foot, avoiding walking barefoot, and to check temperature of bath water. My primary outcome measure will be the time to occurrence of any new foot ulcers, and the secondary outcome will be the occurrence of amputation, that is major or minor, and also proportion of patients. I'll be choosing another secondary outcome, that is proportion of patients with target HbA1c values in the intervention control group. I will be choosing this because we can also see whether frequent contact with the healthcare worker can improve treatment adherence and improve the glycemic control indirectly as well. At the end of follow-up, FPS, VPS, and HbA1c will be repeated in both the groups. Also, as a fidelity measure, patients in the intervention arm will be given a questionnaire to ascertain acceptability of the intervention, perceived benefits, and challenges. My sample size to assess the effectiveness of intervention with an 80% power, the minimum number of participants required is 132 in each group, and accounting for 10% attrition, 145 participants will be required in each group. The primary outcome measure will be assessed using Cox proportional hazards model with the results depicted as Kaplan-Meier curve. And for the secondary outcome, chi-square test and Wilcoxon rank sum test will be used for the secondary outcome. So data collection will be done at St. John's Medical College, will be entered on RedCap software, and edit checks will be done periodically. Coming to my budget, including the personal costs, investigation costs, other intervention costs, ethics committee fees, miscellaneous costs, and institutional overhead costs, it will come to a total of 29,96,950 rupees. Splitting up, the personal cost as have been shown in the table, including the investigator, statistician, study coordinators, 2 trained nurse, and research assistant. And investigations, including biochemical investigation and a vibration perception threshold, will be used. Other intervention costs like travel allowance for patients to come for follow-up, then phone recharge for patient if they are from a disadvantaged background. The next ethics committee fee, miscellaneous costs, and as I mentioned, institutional overhead costs. So this will be my study pro forma. So my public health message is that up to 85%, that is a huge proportion of diabetic foot ulcers and amputations, are preventable. So in resource-poor settings, teleconsultation to reinforce learning, which may be the reason why education is not shown to have such big benefit in other studies. And if we institute behavioral change in this way, it will go a long way to reduce morbidity in this population. Thank you.
So again, 1.5 minute overshooted. God forbid me. Suppose you are admitted for anything in a hospital. How long you will accept a telephonic conversation from the hospital? How long? And that too willingly, that too happily.
So especially if I live far away from the hospital and I have been cured of my illness and I have enough trust in the healthcare worker, I think I will accept it.
If somebody calls you every week
This is
or
a
for an
subjective question.
year,
You can answer what you feel.
for an year, so how willingly you will entertain that?
If the same person is calling me, I think I will.
You will not like that?
No, I will like that.
So you are inviting a person is being called every week. Probably it could be too much for a year. And so it's good on one end, but it may not be very much entertaining on the other.
So if someone is not a smartphone user, can that person be a part of your study?
If the immediate family, someone in the family owns a smartphone.
Because you said even without a video telephone call would do. So I think anyone with a phone might be a part of your study. So just a question related to that, not related to science actually. What's the proportion of smartphone users in India? What proportion of the population? Do you have any idea?
50 to 60%. So.
It's about 60%, you're right. So another question, suppose this study shows that intervention, a teleconsultation intervention helps to prevent a foot ulcer, and you have the power to influence the central government. So how do you propose to do something on a national basis to prevent foot ulcers? Can you replicate this model on a national basis using teleconsultation or something else?
We can develop an app.
App won't work on a national level.
What is working now? Already going on now. You can give an example of what is going on now. When you dial any number, what happens?
Public health message will be coming. So, but that will apply. This will only apply to diabetic population. So, I don't think other people will like to listen to that message.
So that could be a part. Print media could be a part. National television could be a part to take it across the country. Teleconsultation won't be possible on a national level.
What I was thinking was, if this works, then similarly to DOTS for ATT, you can at least inform a family member to be in charge of the patient who will weekly, an immediate family member. So if they can be put in responsibility for the patient, probably it might work better than a teleconsultation.
So any subjective difference between the intervention arms if someone is on a smartphone and on a visual cue they are inspecting and someone is only on a call? So do you think those intervention will work in the same way?
The reason I introduced video call was so that the patient will examine the foot while on the call. So we can actually make sure the patient is doing.
No, I understand that, but don't feel that these two interventions are not equal?
Yes, so they're not. So preferably that's
So
why
outcomes might be different.
Yes.
So I expect that those who are on a video call on inspection, they might perform well. That may not also come, but that might. So that's element of bias. You could have chosen everyone who has a smartphone like you have taken. Only those who could afford a video call with they can spend.
So, but similar to a study done on.
Could you add another third arm with smartphone, non-smartphone, and
Because a similar study done on cardiac failure, in case patient doesn't accept the video call, that is just for account for contingency. Suppose patients in rural area doesn't have network, then the next option will be at least telephonic call and not exclude them completely from the trial. That's the reason why I've put that also a second option, though the video call will definitely be preferable.
Would you like to reduce the monitoring frequency after initial 1 or 2 months?
Yes, so now I think that would have been better. Probably after the first 3 months, we could reduce to fortnightly and then perhaps monthly if the patient is adherent. Thank you, sir.
May I begin, sir? Yes. Good evening, respected judges, respected faculties, and my dear colleagues. Myself, Dr. Piyash Gorgori, would like to use this august opportunity to discuss regarding my dream project, which is bone health in patients with Turner syndrome. I come from Department of Endocrinology and Metabolism from IPGMER, Kolkata. And we all know that Turner syndrome is associated with increased fracture risk. And this has been traditionally attributed to impaired bone health secondary to impaired BMD. And growth and estrogen therapy is supposed to have beneficial effect on BMD in Turner syndrome patients, right? But aerial BMD, we know that is a planar projection, that is gram per centimeter square, is significantly underestimating in case of short stature people. If you can see this cartoon, the smaller cube has the lesser aerial density than the larger cube, despite having the same volumetric density. And this is the simple physics, and which has been coming into light with various researchers, like by means of bone mineral apparent density from Bakalov et al. And a recent paper in just December 2021, by adjusting the height age, the difference in bone density vanishes. So that is actually our question, that actually this thing exists. Let's see. So for height adjustment, it is the recommendation of ISCD pediatric positions that in children with short stature or growth delay, spine BMD results should be adjusted. And for that adjustment, pediatric BMDCS, that is BMD in childhood study, is employed. For this following formula is used. And there is also another notion that trabecular bone score may also give a clue that is not influenced by height. So the preliminary data of ours shows that BMD of lumbar spine is significantly different among patients with Turner syndrome, but when adjusted for height using the BMAD, there is no difference. But the study of ours was not powered enough to detect BMD difference. And it was presented, but therefore I use this opportunity to see that whether any difference exists for lumbar spine, BMAD, and trabecular bone score measured by DEXA in drug naive Turner syndrome patients versus age and sex matched healthy volunteers, as well as how various treatment modalities that is commonly employed like growth hormone estrogen produce impact on lumbar spine, BMAD, TBS, and bone Turner markers. So there are two parts actually. So part one is to detect any differences of BMAD and TBS between young Turner syndrome girls and age and sex matched healthy volunteers. The methodology consisting of the multi-center hospital-based cross-sectional study with the populations coming from individuals attending Department of Endocrinology of 4 eminent sites in Bengal. And the study period is recruitment of 6 months with a sampling strategy of convenience sampling. The 12 years and above age Turner syndrome girls or not on GH or estrogen therapy who have consented to participate will be included as case, and controls will be the age-matched healthy girls. Those patients who are vitamin D deficient will not be included, not on pharmacotherapy like bisphosphonates or having systemic illness sufficient to interfere with bone health. The BMD it will be used by DEXA machine, that is G-Lunar Advanced Prodigy, present in IPGMR Kolkata with a machine CV of 1%, TBS from TBS Insight software from Minimaps, and the bone turnover markers will be employed by electrochemiluminescence in Roscova's E411 platform with the aforementioned CVs. The workflow will be the obtaining ethical clearance from IEC boards at the aforementioned hospitals. After that, the patients will be recruited. After that, they will be undergoing DEXA and followed by assessment of BMAD and TBS for each groups, followed by assessment of bone turnover markers. The sample size estimation will be done from the author's own database where BMAD is employed like this and the formula use this. Taking alpha error of 0.05 and power of 80%, the sample size comes down to 166 participants in each arm. Total sample size is 200 in each arm and total is 400. So the part 2 of the study is to assess the effect of growth hormone estrogen therapy on bone health in form of lumbar spine, BMAD, GBS and bone turnover markers in drug NIFT among Turner syndrome patients. The same methodology will be employed. In the study period will be 5 years. And the previous cohort of Turner syndrome patients will be followed up, who will be prescribed growth hormone, estrogen, or growth hormone plus estrogen, and there will be generation of the cohorts, and they will be followed up for 4 years. And bone turnover markers will be assessed at 2nd year as well as the DEXA, and also as the 4th year. The initial control cohort will again have assessment of DEXA and BTM at 4th year. And therefore, the work decision will consist of principal investigator being 1, there will be 4 co-primary investigators, 2 research coordinators in each site, total 8, 2 lab technicians, 1 for DEXA and other for bone turnover marker assay, 1 data entry operator and 1 statistician. The statistical analysis will be done using SPSS version 23, and the categorical variable will be expressed in mean frequencies and percentages, and the continuous data in form of mean and median. Imputation method will be last observation carry forward. So that coming to the budget, this is the consumables which includes the trabecular bone score software, which is around 12 lakhs. And there will be the various bone turnover markers amounting 25 lakhs to 23,000. The manpower will be amounting to 1,59,000. The total budget summary, including contingencies and the overhead, assuming fee of 5%, will be 29 lakhs 87,564. So what public health importance is it? It is unravel whether any actual difference existing regarding bone health in Turner syndrome patient, and if no, therefore ameliorate the concern of the clinician regarding bone health of this patient. Second part will aim to answer whether any effect on BMD exists. And the details of the ongoing work is presently there is 70 Turner syndrome patients of the said range recruited under WAR database. Osteocalcin of home has been done. So these technologies will help to throw light on the bone health of Turner syndrome patient beyond the notion of BMD. Thank you. Sir, it is ranging from as far as a recent study from West Bengal goes, it is 55%, and some studies show 60%, some studies show 80%. But as far as study from the West Bengal, I have taken it is a prevalence of 50%. Therefore, if you can see in the budget, I have taken vitamin D kit is 96 wells and 8 such. Although my sample size is 400, I have just doubled it.
Your exclusion criteria is vitamin D deficiency.
Yes, sir.
So assuming Turner's, and at least 70 to 80% would get excluded by just a vitamin D.
Yes, sir.
How many would you actually be able to recruit in your study?
Sir, actually, this is an extension of what I have done already regarding my thesis. And in my thesis, I have found that 50% of these ladies will be vitamin D deficient. And in my thesis, I have seen the same protocol, and I have included only those patients who have been vitamin D sufficient. And with that, presently 70 patients is in my database currently.
So what is the duration of your study?
Sir, actually it is 5 years, because there will be issues regarding statistical calculation. There will be issues regarding.
So to get 400 patients, how many should you screen actually?
So at least I need to screen at least 800 to 1,000.
And all of them have to be treatment naive?
Yes, sir.
So do you Can you complete it in 5 years actually?
I think so, because sir, what happens, because I had targeted in my thesis.
But you got 70, that is what you say. You got 70 in your thesis.
Yes, sir.
Getting
Because-
that number is really difficult.
Yes, sir. That's why I chose 4 sites, because in my site, I have done almost 70%. So the into 4, it is 280. So
The other thing is, suppose you get increased risk of, you're not looking at fracture actually. We know there's an increased risk of fracture. You're looking at bone markers. So suppose you get the obvious result that there is a worsening of bone health in patients with Turner syndrome. How do you propose to manage it? Do you propose to give bisphosphonates? Because growth hormone estradiol, they are standard of care. You'll be giving them anyway, irrespective of bone health. So what would be the final outcome of your study? How would it influence management of Turner syndrome?
sir, actually the management of, it is influencing the management of Turner syndrome, because what we see that in adult patients, in my cohort at least, there has been no fracture till now. So what data?
I understand. What I propose to say is,
Yes, sir.
growth hormone estradiol are standard of care.
Yes.
They might have good bone health, bad bone health, any bone health. We'll be giving it. So if you get bad bone health, how do you propose to change their management, or what are you keeping in mind? You are doing this study keeping some clinical outcome in mind,
yes,
some relevance, practical relevance in mind. What is that you are keeping in mind?
What is it going to change? Is it going to increase the use of bisphosphonates or teriparatide?
No, sir. It is actually reducing that risk use of bisphosphonate, because whenever we see a result of BMD of less than 3, we tend to, our basic instinct is to give the bisphosphonate, whatever be. But I am telling that it is not the case, because height has a significant effect on BMD. So instead of BMD, we should look into BMAD.
The study title is more of a generic like.
Yes, sir. I know that.
think you should rework on that.
Yeah,
This was
because-
exactly what I'm trying to study, and the effect of you can write, not like bone health in Turner's, it's like a chapter's
Yes,
name.
sir. I think so. But
No,
my
that
study
carries
is
a lot of weightage.
Yes,
So
sir.
people, you have seen people very, very good study title.
Because sir, my study is a combination of cross-sectional and case.
You can include those.
Yes,
You should not write like bone health in Turner.
impact. Yes,
That should be reflected in the title. I mean,
yes, sir.
Exactly.
Dr. Pias, the age group that you're proposing to include is 12 to 21 years. How are you going to keep them treatment naive? Like you said, you have 70 patients in your database. So if there is a 16-year-old child with Turner's in your database, you're going to keep her treatment naive till we get.
No, ma'am. What happens? These patients come to our OPD. We screen them. We detect them Turner patient. We do the DEXA. We do the DEXA at the baseline. We then give the treatment, whatever treatment it is, depending on the bone age, growth hormone, estradiol, hey, whatever. After
But your part 2 is that you have randomized them to either receive GH plus estrogen or estrogen.
not randomization, ma'am, because depending on the clinical scenario, what the patient requires. Like
There's
if-
one none also, if I remember right. There were 4.
Yes. There will be 4. There are non-patients, because certain patients like ma'am, a lady with an in my cohort, there is a lady with 18 years who had mosaic Turner and who was spontaneously menstruating and who has a height of around 147 centimeter. In that patient, we just keep follow-up like that, ma'am. And in my cohort, if I can remember, around 5 patients is that, right?
So what percentage of Turners have spontaneous menarche?
10%.
Spontaneous pregnancy?
1%. Actually, one or two patients in my has some.
So following up for 4 years at the age of between 12 to 21, I think it's going to be a challenge, because you mentioned that all your patients should be treatment naive.
No, ma'am. Initially, they will be treatment naive. After that first analysis, they will be given treatment. After that treatment, we will be following at 2 years, 4 years. And at 4 years, after receiving each arm of the treatment, how they are going to respond to, because there are no study regarding BMAD
So
on.
what do you think a child who's coming to you at 12 years and you're diagnosing Turner's, and a patient who's coming at 18 years and you are diagnosing Turner's, what do you think is the effect on the bone, all the parameters that you're doing to assess bone health? What do you think it's the effect?
I think actually.
Is it comparable? Can you group them all together in one basket?
Actually, no, ma'am, because we cannot compare, we cannot group them into large total basket. But again, there is a notion that at the child who has presented to me at 12 years of age is shorter. And at the short, and he has also a age, that is notion called age corrected BMD, and that will be improved. Like, let me give you an example.
Just to cut you short, sorry for that. If you leave aside height, a hypogonadal individual at 12 years
Will-
and 18 years, that is what
at the 18 years will be definitely more loss. Yes,
they
yes,
have
ma'am.
comparable
No. There will be the 18 years old definitely will be hypogonadal more.
So you should relook your treatment naive inclusion criteria if you're including a wide range of 12 to 21, because hypogonadism is a confounding factor to reduce BMD in
Yes,
those
ma'am.
patients.
Yes, ma'am. Definitely. Thank you.
Thank you.
May I begin? Good evening, respected faculty and judges and my dear colleagues. I'll be standing here and presenting my research grant application, which is actually my dream project. So if you grant me, I'm probably going to pursue it for the next 20 years. I'm presenting a diabetes study, which is to utilizing comprehensive diabetes app for improving glycemic care targets in type 2 diabetes patient. Dr. Setu Gupta, I'm the principal investigator, and my co-investigators would be Dr. Yashjeet Gupta and Professor Nikhil Tandam from All India Institute of Medical Sciences. So let's come back to the problem statement. Diabetes, as we all know, is a challenging and expensive health problem of 21st century. So much so that alone in India, as per the IDF 21 report, we spent 6,500 crores on overall expenditure in India. And diabetes management, which follows a standardized medical and behavioral protocol, ends up improving quality of life, prevents complications, and prevents premature mortality. So by extension, it makes common sense that effective interventions which promote healthy behavior are an integral part of diabetes management. However, and here is the crux, that diabetes self-management is highly demanding responsibility, which requires continuous diabetes education and support to empower patients. Like Professor Goswami asked, 10% weight loss is easy, but how are you going to ensure the intervention? So this is where I come in, that diabetes apps which support patients in advancing knowledge of disease, including awareness of complications and personal self-management capabilities, have been recorded, and a meta-analysis shows that improvement in glycemic controls does occur by utilizing digital health intervention. IDF has gone ahead and said that well-suited apps are important for promoting self-management, and research to guidance reports state that diabetes is best market for digital health innovation. So combining everything, it is not a surprising fact that plethora of apps are existing on iOS and Android devices, but none of them are complete. And it is said that usually patients end up requiring more than 2 apps, some for diet, some for tracking, some for complication management, some for videos, etc., to monitor them. India, which is destined to be a diabetes capital of the world, is facing a magnanimous burden, and hence early intervention is a necessity. Technology and connectivity boom has been attained. As has been said, that more than 60% connectivity of smartphone usage is there in India. And COVID pandemic, by usage of Arogya Setu and COVID app, has shown that we are sitting on a fertile ground to utilize app-based intervention for increasing compliance with exercise, nutrition and diet, medication and follow-up visits, and educational videos, all the pillars of diabetes self-management. So my hypothesis is that usage of dedicated and comprehensive diabetes app improves glycemic and target outcomes in type 2 diabetes patients. Methodology, it will be a randomized controlled trial. Population would be persons with type 2 diabetes presenting routine OPD. Intervention would be a mobile app called Diabetic. Comparison by standards of care, and outcome would be differences in mean of glycemic target. Detailed discussion would be that I would include type 2 diabetes patient between the ages 30 to 60 years with duration of disease less than 2 years, HbA1c between 7.5 to 10%, ensuring more than 2 visits during the 6-month run-in period, and all of them having an ability to interact with usual apps on their smartphone in either English or Hindi language. I would exclude patients with comorbidities like CKD, CLD, cancer, terminal illness, diabetic retinopathy, active diabetic foot ulcers which prevent them from exercise, and adverse cardiovascular event which required hospitalization in the last 6 months. I would randomize in 1:1 ratio using block randomization with varying block sizes by computer generated random numbers. Allocation concealment would be done using sequentially numbered opaque sealed envelope, and since intervention is apparent, trial will be open label and non-blinded. So what would be the diabetes app would do? It would track daily steps and prompt patients to complete target steps. As you can see, it is prompting Rishi to get up and work. It would display trends and anthropometric variables in lab investigation, which can motivate patients or maybe help them buckle up. reminder for drug intake at appropriate hours, prompt to book follow-up appointments. I like to point out that it will not book up follow-up appointments so as to not include intervention bias, but it would just prompt them. 12 validated educational video modules as has been done in our previous study, and easy to access calorie similar alternatives as eating the same food gets boring, and utilizing game mechanics principle to drive engagement and usage longevity. Game mechanics principle means telling them that we are giving you badges or showing them progress bar or showing a leaderboard of sorts. Primary outcome would be difference in mean HbA1c at baseline in 12 months. Secondary outcomes would be difference in means baseline and compared at 6, 12, 18, and 24 months of all these parameters. Sample size, previous study which was done in AIMS called independent study had shown that taking the same range, mean HbA1c was 8.8 and a standard deviation was 0.6. And using that as a background and assuming that HbA1c reduction of 0.5 is clinically meaningful, allocation ratio of 1:1, 95% power, alpha error of 2.5%. I get 45 patients in each arm, total of 90 patients, presuming a 20% attrition rate. I'll be including 110 individuals totally. So what have we done? I have helped develop videos for training patients in insulin technique at home care for steroid-induced hyperglycemia during the COVID pandemic. I have developed an insulin cost calculator app for clinicians, which is under IGM review. And I have been developing electronic molecules for endocrine cases with ICMR collaboration. Work done by co-investigators on whose shoulders I'm standing here is that MDiap app, which has been validated in 3 studies which showed that SMS tracking actually leads to more weight loss. Subsequently, video-based lifestyle education program and the national importance iTrack project, which is being run in Punjab. Institutional support is that there is a dedicated endocrine and diabetes clinic, inbuilt electronic medical records, dedicated NIS tech support, lab services, and free pharmacy. So the timeline would be that app development would take 2 months of app construction and 4 months of beta testing. During this 6 months, I would be doing patient eligibility and run-in period, recruitment and follow-up for the next 28 months. And in this time, data collection would be done and app would be maintained. And the last 2 months would be the data analysis for SPSS. This is my budget allocation. Initial period of 6 months would be for software development, so it will be taking 50,000. And then this is for the personal cost, tech support, including server fees and app store fees and computer and devices to develop it. Institutional overhead of 10% and everything else documented here leads to a budget of 25 lakhs. Ethical consideration, both arms will receive treatment as per standard of care, written informed consent, study would be approved by AIMS Ethics Committee, and Helsinki Declaration will be honored. And thank you, that's my time.
What do you understand by magnanimous?
Like pretty huge, sir. Like of a.
It's usually used in a good sense. You don't have magnanimous burden of that.
Okay, sir.
ESA grants 30 lakhs, it's magnanimous.
Fair enough, sir. Point well taken.
So in your app, do you feel that artificial intelligence might have a role to play?
So artificial intelligence would come into play once we have a lot of data, once we can actually have data which we have analyzed and computer algorithms runs which actually predict that, okay, this person walks around maybe 6 to 7, not at night. So it's better to give him prompts in the morning rather than at night. All these things will come in when we have magnanimous data, sir. Not right now.
Why not right now? Because an individual will be generating data every day on the app.
So, like I said, that would require a much larger extent of data analysis that this would not cover in this project, sir. As of now, I'm just testing that actually this app helps in improving. Further on, yes, to increase the incremental benefits, it would be required, but that would be cost benefit would go down. Right now, I actually want to prove that, yes, a dedicated app helps. Further on, yes, sir. It would be part of later on studies because I really believe that if we get it through, I'm going to add more and more, maybe include type 1 diabetes, etc.
Why have you chosen individuals having diabetes less than 2 years only?
So because this was something that was contentious and we had a lot of debate. My idea is that it's better to catch them in the early stages where they're actually motivated rather than the later part of the stages where they're accepted that disease cannot be changed and I'm going to be on drugs forever. So in the early part as a trial period, let's just say when they're at motivated and if we provide them with incentives, whether they actually, because as we all know in our practice, the patients in the first year are very motivated that I'm going to lose weight, don't start me on medications, I'm going to follow the lifestyle interventions, etc.
But is there any cutoff threshold which other studies have quoted like 5 years, 2 years, 1 year? No.
So
no such
I
data.
haven't.
And how do you exactly track the steps? Just by means of app?
Yes, sir. So now most of the smartphones have an accelerometer and a gyrometer inbuilt, and most of them
But
do
they
collect
have
the
to
data.
carry while.
Yes, sir. They'll have to carry. That's why all the patients who own the smartphone, not that their parents have it or their children have it, they have to have it on their person. They are a frequent user or they would be enrolled, sir.
That has to be carried while doing exercise so that exactly steps would be counted.
So majority of the time, patients who, when they're walking out, when they're on job, they have it on their person. Matlab, it's hardly when they're sitting and they leave the phone and go for a washroom is when they're leaving it. Otherwise, even when they go out to buy sabji, they are carrying it on their person.
What should be the ideal intervention, if at all?
So it should be a pedomotor, but then that would
be an ideal
add
one.
another layer of intricacies and complications. And yes, ma'am.
That's important. So have you heard of any gentleman called Richard Thaler? Is he relevant to your study? Have you heard of something called the nudge theory? Nudge theory, nudge hypothesis?
No, sir.
So you're using something called game mechanics where there's a sort of positive reinforcement going on.
Yes, sir.
That is a part of nudge theory where you give small nudges to influence an
yes, sir,
outcome. They
madam,
could
I
be
could
direct or they could be indirect. And Richard Thaler was the economist who found it. He got the Nobel Prize in 1991.
Okay, sir.
So he's relevant to your study.
Absolutely.
One last question. So you yourself mentioned that there are plenty of apps available now,
Yes.
right? So apart from the fact that it's coming from AIMS, what is new in your app and what is unique about your app?
Ma'am, first would be that this would be harping on the made in India thing. Second would be that the new would be it would have everything that a patient requires, the 4 pillars, like I said, and it would be built from a diabetologist point of view. Secondly, ma'am, as of now, this is something I couldn't cover because of the time constraint. This would be attached with the electronic medical records that the AIMS have inbuilt. So the UHID, when the patient comes to us and downloads the app, we will enter the UHID, we will enter the password that would be generated on their phone. And now whenever the patient comes to us for a test, because most of the patients get their tests done at AIMS and minor of them comes from Lal Path Lab or etc. So the majority of the patients, when they get tested at AIMS, their electronic medical records would be shifted to their mobile phone and it would be shown in an easy to grasp manner. Like I said, the HbA1c curve, the fasting plasma curve, we will measure the weight so we can enter it. That is what a research assistant for. And in case the patient comes from outside report, there would be a research assistant who would enter those reports with the UHID so that this gets also translated. So that would be, and then it would have everything. It would have the educational video modules. It would be tracking. It would be giving diet alternatives, etc. So we're trying to make it a comprehensive and dedicated diabetes app. And none of this exists as of now. And also these apps, they don't produce data on public forum. Like if you want to go out and actually see what is, you won't get it. But because I'll be doing it as a scientific method, I'll be publishing data.
So what is the outcomes that you're measuring?
Sir, the outcomes would be the glycemic targets like primary would be HbA1c difference at 12 months. And the other outcome variables would be LDL cholesterol, fasting plasma, postprandial class, estimated GFR, albumin creat ratio, anthropometric measures, etc. The usual glycemic targets that we follow, routine care, sir, standard of care. But because it's 2 months, I'm not looking too much at complications because it's early onset diabetes and it's 2 months of duration. So I'm not looking at.
So just going with what Dr. Mangaraj also asked you, why are you restricting to less than 2 years? Because I mean, I think the people who are having diabetes for a longer duration, get more involved in their care. So, in the earlier periods, there are a lot of people who don't want to get
so
involved.
That's the thing. So,
and you're not looking at the complications. If you're looking at the complications, then your duration is important. Then taking lesser duration is important. So how do you address that?
So this was something that we had talked a lot about, and this was more or less, like I said, I did not do a review of literature. What was the cutoff? It was arbitrarily decided as 2 years. I actually accepted, but the principle behind it was that the early patients who come to us lesser duration of diabetes are actually motivated. So let's just target those in the beginning and actually see how they progress.
The other issue is that they are easily managed with whatever form of therapy you use.
Yes, sir.
Whereas those with longer duration of diabetes are the ones who are more challenging to manage. And so then it makes, your app shows the difference. I mean, if you're showing a difference in them, then it becomes even more relevant.
So, but both the arms would be the same kind of patient, sir. It's not that whatever my app will show would that the person who used app actually had a better. It would, because the other arm, the control arm would also.
extrapolate and tell that it will work in diabetes.
Yeah,
Sir,
you can't apply that
yes, sir.
on a larger.
Yes, sir. But subsequently, obviously, I'm gonna, like you said, upscale it and go on.
Yeah,
No,
so
this is for only 2 years, sir. Subsequently, yes.
So
for
what
probably
we are
20
saying
years.
is that why don't you think of having patients across the spectrum of duration of diabetes, and so that it can be extrapolated to work on everybody.
Fair enough.
Whereas your results after 2 years of doing this, you will say that okay, we are going to, this is only good for people with less than 2 years duration of diabetes.
So I'll ask a last hypothetical question because that's important when you are planning interventional research. Suppose ESI gives you the money and you do the study and it turns out to be a very successful app. Now, who would get the copyright for the app, ESI or you?
So I think we would apply for the patent, sir. You helped us fund it, but the patency would still lie with the author or the person who conceived of the idea. I mean, if you look at the startups, you will probably get some equity, and I would probably mention you as thanks, but that's about it.
Plan to do this as a for-profit app. You plan to make it a paid app in the
No,
future?
sir. No, sir. Since I'll be starting off from funding, since I'm starting from a institute of national importance, I'm not planning to earn from it, sir.
So it doesn't matter.
It doesn't matter, sir. But I can maybe quote it in my CV. That's all it matters. Yes, sir. Thank you. So the more aware in regards to what they need to do. Sir, the recent ones. So recent ones are the more interested, sir, because they suddenly come with the how can this be happen? Okay, sir. Okay, sir.
Yeah.
Complications, sir. That is. Sir.
What you are saying, it could be diametrically opposite to that also.
Sir.
Your notion that only who have less than 2 years, they will be motivated, not those who have 8 years with a complication. That is not true.
Those who have shorter duration of diabetes don't want to accept it also. For a long time, they don't want to accept it also. Many people don't want to accept that they have diabetes. So they want to, just say that they are just normal and they want to go along.
These are calls of wisdom from decades of experience. Actually, patients come for the very first, they don't accept for many months.
Okay, sir. I was about to say that initially they would be denial and anger. So in that anger phase, they would be very motivated. But okay, sir. I get back to that. Thank you.
Good evening, everyone, respected judges and faculty, and to all the fellow participants. I am Dr. Shubhashish Niyogi from IPGMR Kolkata, and I will be doing a project on long non-coding RNA from urinary exosome can help to differentiate diabetic kidney disease from non-diabetic kidney disease. So we know that chronic kidney disease in diabetes is the commonest cause of end-stage renal disease worldwide. And if you consider the Indian scenario, approximately 7.7 crore Indians are affected with type 2 diabetes, of whom approximately 20 to 40% have renal involvement. And chronic kidney disease is associated with significant morbidity and mortality, and also financial burden on the existing healthcare system. And renal involvement in type 2 diabetes can be those due to diabetes per se, which is diabetic kidney disease, or causes other than diabetes, which is non-diabetic kidney disease. And in some cases, there may be significant overlap. So the management of the diabetic kidney disease group lies on diabetes control and blood pressure control. However, for the non-diabetic kidney disease group, which is a heterogeneous group, there are specific treatment options available in the form of immunotherapy, and which could dramatically change the patient outcome. So identification of non-diabetic kidney disease is essential. And we have certain clinical, biochemical, and radiological markers which are there to identify non-diabetic kidney disease. However, studies have shown that the role of this markers are questionable, and renal biopsy is the gold standard and the confirmatory test. However, considering the magnitude of the problem and the lack of adequate resources and the complications associated with renal biopsy, it's impractical to do renal biopsy in all patients with renal involvement. And so we need a non-invasive biomarker to diagnose diabetic kidney disease. And in past, studies have been done to find new biomarkers in the form of proteomics, metabolomics, transcriptomics, and epigenetics. However, in majority of the studies, the diagnosis of diabetic kidney disease was not backed up by histopathological diagnosis, and they lacked a comparator group in the form of non-diabetic kidney disease. So we are thinking of analyzing certain long non-coding RNAs which do not code for any proteins, and it has been seen in cell culture and animal-based studies that this long non-coding RNAs have a role in pathogenesis of diabetic kidney disease. And this long non-coding RNAs are MALAT1, PBT1, gas-fare, hot air, NEAT, and TUB1. And we are planning to analyze this long non-coding RNAs from urinary exosomes. Exosomes are basically extracellular vesicles 30 to 150 nanometer in diameter, and they take part in cell-to-cell communication. And why we are choosing exosomes here is because we can we could have measured this long non-coding RNA from free urine, but we are choosing exosomes here because they reflect the damage from all parts of the kidney, from the glomerulus, from the podocytes, and from the tubules. And the circulating exosomes in the urine are not confounded by the plasma exosomes, as because exosomes cannot pass the glomerular filtration barrier in face of severe diabetic nephropathy also. So our hypothesis is that long non-coding RNA isolated from urinary exosome can help differentiate diabetic kidney disease from non-diabetic kidney disease. This can also help in better understanding of the pathogenesis of diabetic kidney disease. The objectives of our study, the primary objective is to study the difference in expression of different long non-coding RNA from urinary exosome in biopsy confirmed subjects with kidney disease. This includes both diabetic and non-diabetic kidney disease. The secondary objectives are to analyze long non-coding RNAs differentially expressed in type 2 DM subjects with a diabetic control, those who have diabetes but without evidence of any nephropathy, and non-diabetic subjects without any renal involvement. And we will also validate this long non-coding RNA as potential markers in the histopathology samples. Now, what is the impact of this research? We hope to identify molecular markers in urine or kidney tissue that will help us to pre-select patients, and which will lead to a more targeted renal biopsy and avoid unnecessary renal biopsies. And in long run, it may help to identify single or composite markers which may facilitate easy non-invasive diagnosis. They may also help in earlier identification of diabetic kidney disease, and they may provide insight into the pathophysiology of diabetic kidney disease. Now, this is the methodology I have summarized in one slide. First of all, I will submit application for ethical committee clearance, and once I get the approval, I will screen subjects. My subjects are the inclusion criteria: type 2 diabetes mellitus subjects in the age group 18 to 65 years with EGFR 30 to 60 ml per minute per 1.73 meter square, and or evidence of proteinuria, either ACR greater than 300 microgram per mg of creatinine or 24-hour urinary protein greater than 500 mg. And this will be done, the patients will be screened from the endocrinology OPD. After that, we will ask for consent for renal biopsy, and those who will consent, we will examine the clinical and baseline parameters, and urine will be collected in these subjects for exosome isolation later. And after that, those who have given consent, we will see that if biopsy could be done, we will get an ultrasound and other parameters and look at the other contraindications, like if they have any bleeding disorder or if the kidneys are contracted. And this all exclusion, after excluding, renal biopsy will be done in the nephrology procedure room, and they will be further classified as diabetic kidney disease, non-diabetic kidney disease, or mixed kidney disease according to the International Society of Nephrology or the Renal Pathology Society classification. And after that, exosome will be isolated by kit-based precipitation method in which equal number of diabetic kidney disease, non-diabetic kidney disease, and matched diabetes subjects without nephropathy and control will be taken into the study. And these exosomes will be characterized using nanoparticle tracker and atomic force microscopy, which is present in Indian Institute of Chemical Biology, Jadavpur. And after that, once we are sure that we have isolated exosomes, then we will go for RNA isolation from these exosomes using trisol method. And the expression of this long non-coding RNA will be analyzed by real-time PCR, which will be done in our research lab. Now coming to the sample size calculation will be done for difference in mean for two independent sample continuous outcome, assuming a power of 80% and 95% confidence interval. However, as far as literature review, no studies have evaluated long non-coding RNA from urinary exosome. So we have done a pilot study in our institute using 5 samples, both diabetic kidney disease and non-diabetic kidney disease, and a pooled standard deviation has been calculated from this study. And considering an error of 20% of the mean and acceptable, the sample size for individual non-coding RNA is calculated. And the minimum sample comes to 45 diabetic kidney disease and 45 non-diabetic kidney disease. And equal number of matched healthy controls and diabetic patients without evidence of nephropathy will be taken. Now this is the budget summary. And as we can see that I have grouped the budget into certain headings like manpower, consumables, travel, contingencies, and the overhead. The total budget comes around 28 lakhs. And the manpower or research assistant will be required for helping in sample collection, data recording, exosome purification and characterization. And he will be also involved in organizing the laboratory results. And samples has to be carried to IICB Jadavpur. For that, travel expenses will be there, and also travel expenses will be required for attending workshops for better learning of exosome isolation method and long non-coding RNA isolation. And for regarding contingencies, this amount will be utilized for emergency procurement of certain items as given here. And the overhead is estimated at 15% of the total cost. And these are the whole list of consumables, what is expected to be utilized. And at the end, I want to conclude by saying that we are hopeful that in this long non-coding RNA from urinary exosome can help us differentiate diabetic kidney disease from non-diabetic kidney disease in type 2 DM patients with nephropathy, and thus act as non-invasive biomarker, which may help us to decrease significant number of unwanted renal biopsies. Thank you.
Applicability at the community level. How many institutes or places, the facilities exist?
Sir, regarding, sir, this is at the point of research development. Sir, if positive results we can obtain, we can go for kit based. As because what is the cost and what is the distribution? As we can see that we will not require characterization of these exosomes later on. As because when we are sure, this is a one-time event. When we are sure that we have isolated exosomes, and exosomes can be isolated using kit-based method, then further characterization will be not required. So that cost will go, or that applicable will go. And if we are, if positive results are obtained, and if you're going to commercialize it, then this can be applicable in the at the community level.
Yeah, what is the basis of picking up these non-coding RNAs?
Sir, actually, in certain animal-based studies and cell culture studies, it has been seen that this long non-coding RNAs is associated with the pathogenesis of diabetic kidney disease. Actually, this long non-coding RNAs are associated with the epigenetic changes related to diabetic kidney disease, and they control certain miRNAs also. And ultimately, they together lead to which are associated with those legacy effect and the metabolic memory. These all things are associated.
Are they different from the ones associated with non-diabetic kidney disease? That is,
sir, actually non-diabetic kidney disease is a heterogeneous group.
Yeah.
So there can be IgA nephropathy, FSGS, and a lot of things.
So are
they do not have that, but this is more specific for hyperglycemia mediated renal injury, because it has been seen in streptomycin induced diabetes in rats, that it has been seen that this long non-coding RNAs are more expressed. So if then the main pathogenesis for non-diabetic kidney disease, for diabetic kidney disease is hyperglycemia mediated renal injury, contrary to the non-diabetic group where there is a primary glomerular disease.
Yeah. So what I'm saying is that if you look at the definition of diabetic nephropathy or diabetic neuropathy, you're excluding all the causes, and when you don't find any other cause, then you call it as diabetic renal disease.
Yes, sir. But sir,
So, whereas you're going to do a reverse in this, where you're identifying certain non-coding RNA.
sir, actually by identifying this long non-coding RNAs, if we see that they are differentially expressed, we can say that these are diabetic. They have an increased chance of diabetic kidney disease. And if they are not and if their expression is not increased, then we will think that they are non-diabetic kidney disease. Then these patients we can go for biopsy, but this will significantly decrease the number of biopsies.
One of your secondary outcomes, you told you can predict the development of diabetic kidney disease with this marker.
There is a question.
How can you have taken patients who have already developed diabetic kidney disease? Then how
Sir,
can you
actually,
predict them?
this is the beginning, sir. After that, we are thinking that
No.
Sir, one thing is that we have taken diabetes patient and diabetic kidney disease patient. If we see that there is a difference in expression of this long non-coding RNAs.
No. In the inclusion, you have taken those who have urine ACR of more than 300 and EGFR between 30
Sir,
to 60.
we have also included diabetes control patient, which are type 2 diabetes mellitus who do not have evidence of nephropathy in the form of either their ACR is less than 30 or their EGFR is greater than 90. And if you can see that there is difference in expression of this, means there is difference between diabetes and diabetic kidney disease, then we can say that once the patient develops from diabetes to diabetic kidney disease, this long non-coding RNAs will be more.
But rather, it would be better you do at a point of time, you prospectively follow up, then perhaps prediction would be
That
better.
is the plan only, just for this.
Yeah, that interpretation is wrong, that you can look at patients without nephropathy now with diabetes and say that, okay, it's not high in them, so this can be used as a
So
predictor.
we will follow up.
That interpretation is wrong. But I just wanted to ask you, if somebody has hyperglycemia and also has coexisting kidney disease, there will be an element of hyperglycemia related renal injury, irrespective of the underlying glomerular disease that the patient has. In those patients, how will be the performance
So
of
that is the
long
mixed kidney disease group.
Yes.
Okay, sir, ma'am, the utility of this study, what I want to say is that, ma'am, we have data from our college, 110 patients underwent renal biopsy, in which the prevalence of NDKD, that is pure NDKD, that is approximately 20%. The mixed group, if we leave the mixed group for now, but identifying this NDKD, or if we are seeing that this long non-coding RNAs are expressed, we can think that it can be either DKD or mixed kidney disease, but it cannot be NDKD.
True.
So we can just, if it is DKD or mixed kidney disease, and we can just, for the time being, we can just defer the biopsy in this group of patients.
That's where I'm having a problem. If you're sure it's NDKD, we are certainly going it with the biopsy. But if your non-coding RNA is increased, and if you're not sure if it's a mixed kidney disease, would you want to defer the biopsy or would you want to confirm it?
Sir, ma'am, we can progressively follow up the patient and we can take into account the other clinical features.
We are anyway doing without your intervention.
So biopsy will be necessary anyway.
Ma'am, but this group of a large chunk, which 20%, that can be excluded from this.
20% is NDKD. They are anyway requiring biopsy upfront, right? That's what after end of your intervention, your assessment. In the others, we are not sure. We're probably going to end up doing a biopsy after follow-up.
So in other words, even those with say non-diabetic kidney disease, they will have some hyperglycemia induced renal damage, and that might show up in the long.
Yeah, so conceptually what we're saying is that if you look at markers for non-diabetic kidney disease, that's better than looking at markers.
Actually, we cannot do that at this moment, because non-diabetic kidney disease is a heterogeneous condition and there are different pathophysiological mechanisms.
Because diabetes related injury would be there in every patient with diabetes. You can't say that.
Are you quantifying them or are you just qualifying them? Is it yes, no, or are you looking at cutoffs for
cutoff values?
So this is a beginning, and we are planning to look at the cutoffs also. That what is the fold change between diabetes, what is mixed kidney disease, and non-diabetic kidney disease?
Yeah, and does it correlate with any of the clinical parameters like the EGFR or the proteinuria?
So which
does it correlate with the staging? Does the quantification vary with the staging, or is it qualitative analysis?
So this has not done.
Look at that.
We have to look.
There is no in vivo data for human studies for this, only animal preclinical studies.
Yes, urinary exosome in 1 or 2 studies has been studied in that is free urinary exosome, not urinary long non-coding RNA, not from exosome. But regarding this, there is no data.
I faintly remember that is a similar study already going on, or has a research grant been applied somewhere for this thing by Professor Sujoy Ghosh?
Yeah, yes.
Huh? So a pilot is going on possibly?
Yes, yes. Okay. Yes, pilot. Sir, regarding exosome extraction, we are doing here only. For characterization, this is a one step.
So, dear friends, with this we come to the end of this session. Now let me invite an open criticism from your side, a feedback about the so-called judges over here. Anybody who will like to volunteer?
So we should ask them tomorrow after we give the results.
why I'm
They'll
asking,
be candid.
I-
Now they'll be scared to tell us the truth.
Yes.
That
Why I'm
is-
asking this thing? Because what I found out of many Tysa, the people who are sitting here, whatever you call them, it's a very, very simple team, very sophisticated, very soft-hearted, and nobody put anything in very harsh words or loud words. This is for the first time I'm seeing. Almost bearing initial 2 or 3 candidates, everybody overshooted the given time. In a competition, you should not overshoot time. This is a strict and mandatory thing to do. So 1 minute, 2 minutes, 3 minutes, even 4 minutes. So it's too much. So you are always marked negatively for that. So which probably with this team, nobody probably did. I did for one candidate. Number one. Number two, one suggestion from my side, whenever you are presenting, you are just a gate away from coming to our side. After your DM exam, you will be on this side. You will be presenting on many platforms. So whenever you are giving a presentation, whenever you are making a slide, keep it concise. It should not be a sentence. It should mean a selected words, that's all. And you should elaborate them. Whenever you are writing something in sentences, you are creating confusion. So the person sitting in front of you will, if one goes on reading, he or she is missing some words. If one is listening, one is unable to focus whatsoever you are presenting there. So audio visual conflict is there. So make a concise slide. You elaborate it. That is always a good presentation. Always use a font which is clearly visible. In a bigger font, simple fonts rather than so most of the persons, they have used this thing. So these 2 or 3 things one should remember. Sometimes it's very confusing. So if the person sitting in front of you is unable to grasp what you are saying, the entire purpose is lost. Best wishes. So not invited any criticism.
Absolutely correct. Only thing some of you have done actually included your previous studies and possibly ongoing work. Whenever you put up a grant application that carries lot of weightage, a standalone money nobody is going to give you unless you say that I have been working on it, I have some experience on it, I have published something on it. Then only people would try and look at you more closely. If you just ask, I want 50 lakhs, I will do this, they'll say thank you. So always you should keep that as one of the criteria. At least 3-4 have done good. That is one of the important thing whenever you are submitting a grant application. So standalone grants, nobody gets, and the 30 lakhs, 50 lakhs, nobody gives. ESA keeps on giving 2 lakhs, but that is not going to make you anybody anything. Okay. So all of you are done with any other comments you want to share? May not be criticism, we will listen tomorrow. We will go to MCQ round now. So all of you are ready. just write your name on top, and then we will go in the sequence order. You have the options of 1, 2, 3, 4. Okay, seating arrangement is a bit difficult. Can we spread out the tables so that they are more of a U shape rather than a absolute? This V is more so that you are able to see. Yeah. Then just make the direction a bit instead of pulling them apart. Just take angle, give an angle. The other direction, away. Yeah, it should be correct. It should be in that direction, correct. Just let them keep it in front rather than collect. Yeah, that is the best way. Keep it in front of you, visible to all of us. No, फिर collection मुश्किल पड़ेगा. सामने दिख रहा है ना, बुढ़े ना दिखा दे. अपने को मुश्किल पड़ेगा. Unnecessarily फिर collect. नहीं वो देख लीजिए भाई. बस देख लीजिए. आप तो नहीं चाहिए. हाँ, टाइप डाल. This will move on its own. This will move on its own. This will move on its own. नहीं, all of you just write your name, question numbers 1 to 15, because rest will be a buzzer round where we will be just marking the answers, whoever has pressed the buzzer. 30 seconds per question, it will just move ahead to the next question. 30 seconds.
From here, it should not continue. Yeah, means it won't go. No, here 30 it will not go to this. No, it will be same.
For the first 15 institutions, just write the option. 15 number option correct. Let's see how to do that.
for this? Oh. This is too much to discuss. Too much to discuss. They'll get a quick see. They'll get to quickly see all of that. They cut and make it another. Yes, change it to another presentation. I think they won't understand anything, but still it's a quick view. I know. But Tysa background. This one we don't need to keep a timer. We can move it. Don't give the timer because somebody pressed, some confusion is there, it will cause problem. This is as per doctor's note. Because it's a university, I write a separate report.
Don't do that. इसको zero कर दो. Keep it two. Keep it two. Control set कर दो. Control set कर दो. We will do that. उसमें नाम के साथ +4 -2 ये 30 seconds है this one वो 0 होना चाहिए चेक किया हमने वो वाला मोड कहाँ गया व्यू मोड जो दो आता है
Presentation slide mode में डाल दे ये और तो यहाँ से कर दूँगा Are you all ready? देखते हैं We'll just see from here. It's not कौन सा नहीं अभी तो मैं बोला इतना क्या 15 मिनट तो जितना एग्जाम होना था उतना टाइम तो यहाँ लगा है It's moving, it's moving. Just see 30 seconds that I'll wait, and that is the end of my 30 seconds. No, no, ठीक है. No, no. I'm ready. Anyway, they're ready. Anyway, they're ready.
Question will flash in an instant.
It will stay put.
For 30 seconds, each question.
It is not flash. Yeah.
First question for you.
We'll only know. ठीक है. Just count 30 and then move. Just count 30 and then move ahead. ठीक है.
Oh, only 120, it is changing now. Doesn't. Hmm, 45, 46, 46. 50 कर देंगे. अच्छा. दूसरा वाला कहाँ से किया वाला कौन से किया बचा रहा इसमें लेकिन मैं ये नहीं इसमें टाइम नहीं डाला है सर नहीं इसमें टाइम नहीं है ना बजर के करेंगे टाइम नहीं है इसमें that will become
All your buzzers are on.
Just reset it. She has. Who has green? All the mics. So whose buzzer goes green, he or she will be allowed to answer, but you cannot read the question after pressing the buzzer. If you miss it, it's going to be -2. Please tell your names. We can have some bit easy in scoring. Name, it will be better.
This is something like a roll number color in alphabetical order. It's an easy way of mark. So you don't put that mark in your friends.
Otherwise, you can tell the answer first, then your name. It's so fine. You tell the answer first, then you can tell the name. So shall we start? Okay. Press now.
If you press, then it's -2 without press. Wait. So here we start. Okay. Are we good to go? Yeah. Next up. So once it's removed, you get to see the first question. Wait for around 30 seconds, so it moves to the next one.
Please tell the answer.
The PR diet, Dr. Karthik, Chronic complex PRKARI gene mutation, most common pituitary tumor is GH producing. You are correct.
Tell the answer.
Aladdin mutation. Depression, Balbucin. Finding mistake plus a cardiac index.
No, you identify the disease you have told. The gene.
Aladdin gene,
Triple A gene.
Sorry, Aladdin. Gene name is Aladdin gene. Syndrome is triple A.
No, you can give him half the marks. +2. +2.
Okay.
+2.
Next question.
Previous press. No. Next. Tell the answer. No, it's negative.
Similar.
Negative. Next. Tell.
G is ABCD. Adrenal explain adrenal system. ABCD one.
You can give full marks now.
Pituitary stalk interruption syndrome. Ectopic pituitary white spot, small pituitary, and the stalk is interrupted.
Correct. Pituitary is absent.
Yeah.
And this correct. Your name? Done. Yes. Okay. Next. Tell answer. Unable to see what's first. Stand up and tell. Tell your name. Mark. Tell.
Osteopathy or stat B.
Incorrect. Negative. Tell your name. Done. Yes.
Is the last.
Next. Tell.
One is awesome.
Correct. Tell your name. Done. Yes. Oh, fine. Yeah, too much trying to get a negative mark. Nobody is trying.
We can show the topics for debate. We will come from this side. No, they just pick up the law. That is it. And then essay writing we
Just see everybody has written their names.
Topics not. We will circulate this from this end. We will just become the उसके बाद then we will use the topics for essay.
Sir, that has not been made. We'll just tell them. What? Okay.
Yeah.
I think next we'll introduce the debate topics. So I will just explain some basic housekeeping rules for that. So all participants will be divided into 6 pairs. Each pair will be allotted a unique topic. Today we'll give you the topic name. And as already told by Hari sir, we will not reveal who is going to speak for or against. You have to prepare both, and it will be only be revealed tomorrow morning prior to the debate session. 10 minutes will be allotted to each participant, and kindly stick to your time. We will give negative marks if you overshoot, and there will be 2 minutes of rebuttal. The first bell will ring at the end of 6 minutes and the final at the end of 8 minutes. So you have time to summarize your debate. The jury will be scoring based on various domains like organization clarity, scientific knowledge, the rebuttal, the arguments, and the presentation style. So cumulatively, it will be around 100 marks. So we'll give you debate topics now, and we'll
So the debate topic, for example, one. So two of you who get the 1 number 6 will be competing against each other. For and against will be decided.
You can start from that and he will take 30 hours. So he had the maximum option to show the topic. This will select your opponent or friend or partner, whoever it is. And the topic.
And you have to enlist your names together so that you don't exchange these amongst yourselves. Because
just write your names on the sheet and revert it back.
Write the name at the back of the chick and throw it back again.
So who are the ones? So 2 ones. Just write your names and give us that. So you know the topic.
Radioactive.
Who are the twos? TKO antibody. Okay. Just write down your topic. Who are the threes? Okay. Insulin pump. Fours. All hypertensive. Okay. So take a photo. Fives. 1, 2. Okay. Bilateral retinal. 4 here. 4 here. 6, 4, 6, 1, 7, 6. Which comment are you? 5, 5. Which the other 6? 6 is Karthik. Okay. Yeah, please. That is for your homework in the night. So all of you are aware about the topic? Comfortable? Yes or no, we will decide by Lord's again tomorrow morning. Okay. Right, again, normal SRI, but depends some topic, the common topic for all. It is the easiest topic. Can write any amount. Ideally, when I don't know, nowadays it's not such exam. When I post graduation, it used to be 1 PR paper, only 1. For 3 years, you just have to write, keep on writing on a particular topic. So out of 4 papers, no, one, the last one used to be only a single question. Yes, you have to each one carries 100 marks. All rounds are equal. So your essay also carries 100 marks, and the heads are generally the standard introduction, exercise. Normal, how you write it, reading. How do you write a long answer? You could give a heading, you just don't. The standard format. Also, if you want to make diagram, you may look at all of them. All of you, the breakfast is going to be the restaurant. Okay, because tomorrow, most of you would be traveling, so the faculty would be traveling. You should try and start by 9. But tomorrow there is no question answer like today. By and large, debaters only finish off breakfast and without slides. That's it. Normally, conventional debate you have slides. Here we said actually we don't keep the slides. That's the only problem. Actually, we discussed a lot whether to give instant debate topics or give some overnight debate. Because initial discussion was we should give an instant debate, but some preparation. But there won't be any slide support for it. Everybody will be speaking except how you are presenting it. उसको वो इधर है उसको बंद ये था क्या
ये पेपर देख लेते हैं
They give you papers, no?